So yesterday we covered mostly lymphatics and a lot about anatomy and the physiology of the lymphatic system. Today we're going to go into more detail about the venous system and compression, pros and cons about compression. So venous edema, evaluate and treat. Acute edema, which usually rolls out really easily. After everything else makes sense, then straightforward acute edema makes sense, but rarely do we ever get someone with acute edema who's uncomplicated. Generally, they will not need skilled intervention, so we end up having to assess for the underlying complications that are going to keep an acute person from becoming chronic. And then we'll spend a good bit of time talking about compression. So just a quick review about the cardiovascular system and the lymphatic system combined equal the circulatory system. Your cardiovascular system, I think of it as a highway. It's going to carry much more volume and speed. It's capable of moving liquid out of an area, excess liquid out of an area very rapidly. But the problem is it doesn't take with it the waste products and the recyclable products that you want to get back into your body. So your proteins, your any kind of waste and debris, which causes that area to not get essentially cleaned out. And so the quality of the interstitial fluid becomes condensed if you only go out through the venous system. And sometimes that's okay if what you've got there is excess liquid, but not an excess amount of waste products or protein. So that's what the big debate between whether you need to do stimulation of the lymphatic system or is it safe and appropriate to go straight through the venous system. So when we think about the venous system, just as a review, you've got your pulmonary veins, which are carrying oxygenated blood back to the heart. But when we think of the venous system, we're mostly thinking of low oxygen blood that needs to be removed, and it's going against gravity. So the primary problems we tend to see are in the lower extremities because they're patients who may be immobilized, they may be in a state of inflammation, or they just may be not moving. They're just physically not getting much movement. So the venous system, you've got your superficial compartment, your deep compartment, and then the connection with the perforators from superficial to deep. And you have valves throughout. If you have good condition to your vessels and good valves, it's going to be a one-way direction. But with time, with damage, injury, age, genetics, a number of things can cause people to have problems with their valves and the quality of the vessel. And then you can get regurgitation and so forth. So we'll talk a lot about that. The wall of the vessel is not muscular. They're much more reliant on external forces. You have the intrinsic of the heart, but you're much further away. So the further you get away from your pump, the less effect that's going to have on the movement of blood through the system. You're very dependent on the skeletal muscle pump. And so when you think about the deep vessels and the fact that they're in the fascial compartment and they're with the muscles, if you utilize that, range of motion would be good, but not as good as an active contraction. An active contraction is good, but not as good as a full contraction through an entire range of motion. So think moving a muscle through the entire range of motion with resistance would be optimal, but that's not always possible. So we have to think as the clinicians how to make it as optimal as possible. So we've got the skeletal muscle pump. We've got valves that prevent backflow, whether or not they're in good shape, cardiac pressures, so getting the heart pumping, and then the respiratory pump. And we talked a lot yesterday about how breathing is underrated. We want to encourage a lot of deep breathing, especially when you want to get things moving through the deep vessels. Okay, so just a little review about the interstitial fluid. The idea that it's hydrostatic forces that move liquid across with, so you basically got the semi-permeable blood vessel. And the blood vessel allows liquid to cross in and out, but it does not allow solids in a typical situation to cross over and back. So you've got this combination of hydrostatic pressure that's going to, at the arterial end, it's going to be forcing liquid out. At the venous end, it's going to be allowing liquid back in. So when you think about this, as blood's running through, and we've got this mixture of capillaries running like a web, one capillary might be right next to another capillary. This one's at the arterial end, this one's at the venous end, and liquid can come right out of this one and right back into that one. So in a good situation, your interstitial fluid should be exchanging all the time. So when you think about it, it would be this active exchange frequently. Now osmotic pressure, it's a balance of solutes. So the sodium, basically your electrolyte solutions, your protein, these are going to act as also pressure. So the osmotic pressure is going to usually be pulling liquid back in, keeping it from leaking out. So when you're out of balance on those levels, those could be causing metabolic problems and widespread edema. Okay, so the hydrostatic versus osmotic, and then to review, the oncotic is a subcategory of your osmotic, and so it's the protein itself. Oncotic pressure has been this study, a very ongoing study, because it's what is often related back to the problem we run into with lymphedema. And lymphedema is described as high protein edema. And so in a high protein situation, in the external, in the interstitial fluid, you tend to lose that balancing act, and you actually are causing liquid to be outside the vessel. Okay, so why does edema occur? Just to review again, too much hydrostatic pressure within the blood vessel, too low of oncotic pressure in the vessel, so low protein, or too much protein outside the vessel in the interstitial fluid. Increased blood vessel permeability. So this happens in a state of inflammation. So we'll talk again today about inflammation and how the blood vessel permeability is increased, allowing solutes to pass out. With that comes more liquid. And so it's a one-way street. It can come out, but the solids can't get back in. And so they're passing out into the interstitial fluid, causing an imbalance and causing edema. There's also decreased fluid clearance during a state of inflammation. So your lymphatics aren't going to be acting normally. They're not going to be pumping normally. The permeability of your blood vessels are going to be purposefully slowing things down so you get hemostasis in order to get clot formation and stop blood loss. So all of these serve a really good purpose during a state of inflammation, but the problem can be if it goes on too long, that edema it can cause other negative consequences for healing. So we'll talk about how to deal with that during a state of inflammation and how to try to manage this. Also, many things can happen at the level of the tissue. So tissue changes, whatever tissue you're talking about. So we talked about kidneys, we talked about any problems that you could have with kidney function versus muscle spasm versus fibrosis. Any kind of tissue changes could have ramifications on the resolution of edema. Okay, so this diagram we talked again about yesterday, and thinking about how liquid gets in and out of your body and talking to patients about it. A lot of times I'll talk to my patients and say, if you don't have good things going in and you don't have bad things coming out, then you're holding it in, so talking about the exchange of everything coming in and going out, and how your body's ability to produce clean urine. I mean, a lot of times I'm asking my patients, what's your urine look like? How often are you going to the bathroom? That's a good indication of how much waste products are in your body. Are you having bowel movements? If you're not, again, that's an indication that you're holding in waste. Your body is not getting rid of it. That's also an indication why your leg is swollen. So all of it works together, and it can be a good indicator for your patients, helping them understand the need and looking at what we see as a good outcome and those markers that can increase compliance. So the vast majority of just regular liquid goes into you through your gut into your venous system. But those fats and those proteins and all the solids that we need to absorb are going to be taken up through the lymphatic system. And that way, we think of a lot of bad things that we take into our system. We want to make sure the bad things aren't brought right into our venous system and circulated through our body. So it has to go through those checks and balances of the lymphatic system, and it takes longer, but that's one of the ways in which you absorb, example, fat. And then depending on what tissue we're talking about, it's going to determine on what happens, how much liquid comes back out of it, such as if you're sweating or if it goes through the kidneys, a lot of that liquid will be excreted. Okay, so looking at that fluid, talking about acute versus chronic. Acute is defined as a rapid onset and a short course. So those, it should be resolved quickly, but a lot of times we get the folks who because of complicating factors, they don't resolve quickly, and therefore we have to look at them and think, given their disability at this moment, what's the best thing we can do? How can we get as much return on investment of whatever the patient is capable of doing? And so a lot of times we can get super creative and help them resolve faster and not become chronic. Now on a chronic side, a lot of times you'll find out that this person has had this condition for a persistent and lasting period of time. Again, I like that terminology. Something that is helpful to use is, that this person has a persistent and lasting condition, whatever it is, a disease, a medical condition, one that has evolved slowly over time, and that if you don't develop a persistent and lasting change to their day-to-day, whatever their day-to-day looks like, then it's going to be a temporary fix. When I evaluate patients and explain to them which conditions we're looking at are chronic, and that if you continue to do what you've been doing, this chronic condition is not going to get better. Here's what the future looks like, and these are the problems that are going to develop. And explain that even small changes in a day-to-day basis can result in an improvement. But we don't want the frequent flyers. I mean, we're probably not the best business people in the world, but the reality is those frequent flyers, they get therapy, they get better. They're off therapy, they go back to the previous state. They get skilled intervention again, then they go back to their previous resting state, or that dysfunctional state that they were at. My goal is always to at least keep them above where they were before. It may not be the peak and the best and the gold star treatment, but hopefully it'll be a little bit better than where they were before. My goal is always not to see them again. Hopefully we did such a good job that you don't need any more therapy. That's not always the case, but we can shoot for that. Okay, so reviewing the idea of acute edema and the symptoms. We've got redness and heat. So the temperature and area and redness is due to the vasodilation. Blood vessels sense the need for, it's an emergency, basically, from it's sensing the need, and the blood vessels dilate, blood flow is increased. You can see erythema. You should see blanchable erythema, and that's always something I ask people, is it blanching? Is the redness that you see, you push your finger on it, you empty the capillaries, you let go, they fill back up again. So that capillary refill. So that's due to the vasodilation and the permeability of the vessel. Edema, when the blood vessels are more permeable, more liquids are coming out with the solids, causing edema. You also have the initial lymphatics, which are inhibited. So basically, there's a temporary, should be temporary, state of poor fluid clearance. The lymphatics aren't working as well. It's a state of stasis in order to protect the area. We're meant, our bodies are amazing. When you get hurt, we're meant to stop and rest, hold it still, let things stabilize. Once they've stabilized, we're supposed to get moving again. Think about the caveman age, it's like you've got a temporary period of time to stay still, but then if you want to continue to live, you got to get up and get moving again. Where our education comes in is helping people understand how to move and when to move, because a lot of them, they don't know, and they're afraid they're going to hurt themselves, and they think rest is the important thing, and they don't really know how to begin moving. So we'll talk about that as well. So valve leakage, increased inflammatory mediators, so the presence of inflammatory mediators will reinforce all these things happening. They don't last long, they don't live long, they're not active very long. So if you can get normal physiology going, then it resolves itself, basically. And those inflammatory mediators are either removed from the area or stopped being produced. So the combination of pain, when there's edema, there's more pressure in the area, therefore the nerves are going to be firing. The presence of decaying tissue, so the breakdown of dead tissue, is releasing enzymes that cause the nerves to be hypersensitive. So the tissue itself, the nerves will fire more easily. There's more pressure. This causes decreased function. The patients don't want to move. It hurts. So if you can resolve the edema even a little bit, all of a sudden there's more movement. And that can, that is a huge part of an acute recovery, is getting that edema under control. All of a sudden the patient can move. It's this tipping point that occurs that everything starts getting better. And a lot of times that's undertreated, at least in my opinion and the things I've observed. So it's a self-limiting situation when it's caused by acute changes. If you eliminate the cause, you eliminate the inflammation, and then the edema is much easier to resolve. Now chronic, there's something chronic going on. Why? So your job is going to be to figure out the etiology, because if you can treat it safely and appropriately, you have to figure out what caused it. So identifying etiology, number one, very important, and that comes with basically a holistic evaluation. So what in the system is not working right in order to make sure this liquid is moving effectively? Okay, so as a systems assessment, one of the systems you're going to look at is the venous system. If you look in their history and you're identifying problems that would be indicative of somebody with a venous problem, you might have DVTs in their history. You might observe them and see that they have varicosities. Yesterday, I know we talked a bit about genetics. I mean, my grandmother had varicose veins, my mother has varicose veins. It makes sense that if I inherited that condition, unless I change something about the way those, that they treated their body, and so maybe I can be a little better off, but the likelihood of me getting them is high because I'm genetically predisposed. So some of this goes into also when you go to the doctor and they have you fill something out and say, familial, what did your family have? Did anybody, my dad had a heart attack, my mom had a stroke. Mine didn't, but I'm just saying this could be histories that you're getting, types of cancer, those things that they've identified are genetically passed on and making it more likely that you have these conditions. But looking at your patients, it also helps to ask those questions and understand what they may be predisposed for, especially going into procedures before they have that knee replacement, before they have that hip replacement, anything elective, they should be considering the pros and cons and any kind of predisposition for, infection, poor healing, anything like that should be discussed with them so they know the complications. Obesity. Someone who is obese, the longer and the more significant their obesity has been, the more likely they're going to have problems to their venous system. It puts a lot of pressure on the area. The limbs don't move as much. The pressure, the constant overwhelm on the venous system will damage the veins as well as the valves of the veins. Pregnancy, if I knew then what I know now, at this age looking back, I did a lot of the things right when I was pregnant, but I do think too much time sitting, stagnant, anything like that, I would have probably been more compliant with compression stockings. Everybody when they're young, they feel more indestructible, so they often don't respect and take care of themselves the way they should. But every time you're pregnant, that period of pregnancy puts a lot of pressure on the veins and valves of your lower extremities and can damage them. Any period of edema that you have, the longer you have the edema, the less compliant you are with resolving it, the more likely you could have problems. It could be just the last even few weeks if you get very edematous and nothing's addressed about it. Just the combination, how much volume of edema for how much period of time. So it could be a little bit for a long period of time, or it could be a lot for a short period of time. Any of those things could damage. Inactivity. A lot of people have desk jobs, and they may be otherwise fairly healthy people, but they have years and years working at a desk or even standing. So some people think that if you stand, that's okay, but just standing still is, I'm not going to debate it. I don't know how good the studies are, but anything just stationary is not going to keep that blood moving very well. So I know somebody who maybe stands behind a counter or at a register, or even nurses. They may be walking from room to room, but if they spend the majority of their time standing at a cart, that also is not necessarily a positive thing. So sitting at a desk, standing, just being stationary. Smoking, we talked a bit yesterday as well about smoking and, smoking and just bad habits, bad daily eating habits, anything that you do that is a habit that you do every day. If it's not helpful to your system, it can cause cumulative damage. So smoking is definitely one of them, and because it's a habit-forming addictive situation, it's not easy for people to give up. And so again, talk to them about, you know, from a human perspective, about are you open to discussing it? That way you get on their side and your partner's in it. Having wounds, and we're going to talk about how wounds develop in the venous system. And the number one most common place to develop a venous wound is proximal to the medial malleolus. It's called the gaiter area, G-A-I-T-E-R. I know I went to University of Florida, but it's not that kind of gaiter. It's this area, proximal to the ankle, distal to the knee, is called the gaiter area, G-A-I-T-E-R. So wounds in that area, that's where they're most vulnerable when you have this poor venous return. Now, things you're going to see when you evaluate a patient. Edema of the lower leg. That improves with elevation. So that's really key, is you ask the patient, how do your legs look? First of all, how do you sleep? You know, do you sleep in a bed with your legs up? And if they do sleep with their body level in a bed, their legs look significantly better in the morning, and then as the day goes by, their legs swell up, that's a very strong indication of venous impairment. If they say, you know, for a long time, my legs would get swollen as the day went by, they would look really good in the morning, and I could get my shoes on first thing in the morning, but then as time has gone by over the years, now they kind of are swollen all the time. They're swollen when I go to bed. They may be arguably better in the morning, but not much. Now they're not. This is someone who I would say has mixed etiology. And so they maybe had venous disease for a long time. The venous system was the primary problem, but now there's been a buildup of waste in their tissue. So time after time, day after day, they're building up and overburdening the lymphatic system. And so now it's become a mixed etiology. Yes, there's a venous return problem, but there's also a lymphedema problem. And so we'll talk about how to manage them, how to get a good result on those types of patients. Hemosiderin staining, let me show you another picture. So basically, this is somebody who has a lot of the characteristics of venous disease. The wine-colored, rust or brownish-colored discoloration, that's called hemosiderin staining. It's a byproduct of hemoglobin. So basically, hemoglobin not being able to circulate and do what it's supposed to do, if it is allowed to break down in that area, it stains the tissue. And that is a stain. There are a few things that you can read about that have been found to help reduce this, but anybody who has a significant circulatory problem, a doctor is typically not going to use those things. So it's a cosmetic problem, not something that is likely going to resolve. I see this all the time. I'm sure you guys do too, out in public. It really breaks my heart too when I'll see somebody who looks like they're capable of ambulating and they're riding on a little cart, and you just want to say, oh, you're not doing yourselves any favors, you know, and they're not wearing compression. And, you know, that's the lovely thing about living in Florida is you get to see a lot of diagnostic things on people's legs. So the hemosiderin staining is something that doesn't happen overnight. Now, there is something that does happen overnight that you want to be aware of, and that's called, it's basically busted capillaries. It's called petechiae. They're going to be little purple spots, and so you've probably seen them before, and it's a negative thing. You don't want to see that, and that is something that can happen overnight. Hemosiderin staining happens over months and months of time, so it comes on, what is that, a slow, chronic issue, and it's a sign of a chronic issue. Petechiae is a sign of a short-term something done wrong, and typically you'll see it when there's too much compression applied. So one of the things I think I said at least several times yesterday, and it's a really important take-home message, is you don't ever want to imagine yourself pushing the liquid. Because to me, if you're trying to push the liquid, instead of making sure it's being sort of sucked out of there and it's being encouraged out of there, if you're pushing, and we talked also at length about the amount of pressure it would take to basically over-compress and collapse a blood capillary versus a lymphatic capillary, a lymph vessel. And the reality is we don't know the exact number, but if you compress on somebody and you haven't done all the work to try to make it have somewhere to go, if you exceed the breaking strength of that capillary, it'll basically pop. It'll damage the capillary. So if you've done compression on somebody, and when you go to remove the compression to assess them and rewrap, if you see those little purple spots, that was too much compression. That was exceeded the amount of pressure that they could tolerate, or you didn't, maybe they weren't compliant. You may have taught them what they should have done, but they didn't do it, and therefore the capillary, the pressure in the capillary, it had nowhere to go, and therefore it exceeded it and they broke. So those little petechiae are not a good thing. You probably hear about them in the movies when they say that their eyes had petechiae after someone got basically choked. So upper body pressure also can cause petechiae to form in the capillaries or the eyes. Okay, so hemosiderin staining is that chronic onset of discoloration. It's not sudden, and it doesn't resolve. Petechiae can resolve, and it comes on quickly, and it resolves more quickly, but it's a negative side effect. Weepy tissue. So let's talk about how venous wounds tend to occur. I'll give you a little picture so you can kind of see. I mean, this is actually open tissue. But weepy tissue would be where this person, over time, all of a sudden starts saying, you know, sometimes this area of my skin is sticky. It may feel sticky and wet. And so what happens is, when the venous return is not effective, so there's too much pressure in the venous system, that liquid needs to get out. And that liquid starts to exceed the pressure, and it starts weeping out into the interstitial fluid. Well, as the interstitial fluid increases and increases, and yesterday, I talked about trying to visualize what does your tissue look like. So if you think about the dermis, if you think about your soft tissue, and the layers of your skin, they're just cells held together. So you've got cells that are held together, and any tissue is, but it's all different types of cells. And so you've got the cells held together, and then in between the cells, you have your interstitial fluid. Now, all mixed in there amongst your cells are your blood capillaries and your lymph capillaries. And we are hoping that we've got a nice connection of the tissue. We've got liquid coming out, bringing good things, flowing back into the other end of the venous end of the capillary. And we've got the lymphatics pumping away and removing any waste products that are building up. So we've got this nice clean area. Well, when you have this stasis situation, when the venous system isn't working well and blood's not circulating out of there, excess interstitial fluid forms. And then you're going to picture just this overload, so you've got basically this stagnation, this blockage, and you've got too much liquid. And there's pressure building up, too much space between the cells, and eventually that has somewhere to go. That tissue becomes impaired, the tissue isn't functioning well. A lot of times they'll have had chronic cellulitis. So you may have a person who's had edema long enough that they've had this cellulitis occurring a couple times a year. They may tell you, well, yeah, I had to take antibiotics last year because I had cellulitis, and maybe they now are on antibiotics again because they have cellulitis again. That kind of thing is an indication of chronic situation. Okay, so this is what can build up over time, and all of a sudden that liquid has to have somewhere to go, so it's kind of weeping out of the tissue, and that tissue is getting wet all the time, and it's sticky. So as it evolves, you can develop what is blister-like over the area. What's the next picture? I mean, this is a really good picture that kind of, the coloring isn't great, but it kind of drives home the idea of what I'm building at, is the idea that the surrounding skin, I should have a bigger one from further back, but basically this is more the weepy, liquidy, the tissue is fragile, and it's kind of wet all the time and sticky, and then you get this buildup and crusty outside layer. Eventually, you get an open wound. So eventually that tissue becomes so fragile that some little part of it sloughs off, and they have a small area. So it tends to start more as kind of an isolated small area, but the surrounding skin is not in good shape. But then what happens is once you get one little open area, the liquid has an escape now. And so the liquid starts just sort of draining out, and it becomes overly wet. And so the surrounding skin gets wet. You've got this already vulnerable tissue that isn't very healthy, and now it's too wet, and then you get another wound. So what happens is you tend to develop, for example, you can see these have merged, but we have this other wound here. They usually start as maybe one, and then there's wetness around it. So you get this maceration, and you've got this other one that kind of cropped up over here, and then they merge together. So you can see these were two different, and they merged together. And from a wound care perspective, when you're evaluating the patient, you don't want to get tunnel vision. You don't want to just look at the wound. I mean, my immediate concern is I want to do something to stop this from getting worse, because a lot of times they just all of a sudden just get much, much worse very fast. But the underlying problem needs to be addressed. A wound dressing is not going to fix this. That's, as we talked about some yesterday, we talked about the liquid that's coming out. You can absorb it and remove it, but there's things coming out that they still need. There's a lot of protein coming out, there's electrolytes. These can be very heavy draining wounds. And if you just are removing the drainage, yes, you're maybe preventing the rapid decline of the surrounding tissue because of that sort of maceration around the edges, but you're not necessarily treating the underlying problem, which is poor venous return and the edema itself. So without treating that, the wound's not going to get better. And many, many people just get really focused on a good dressing and maybe modalities at the site, but what you have to think about is what's causing it and can you eliminate the cause? Okay, so going back, what did I miss? So open wounds that evolve in that way. So they tend to be irregular in shape. They tend to be fairly superficial, and they don't tend to be big, deep, gaping to the bone. They tend to be rather superficial. They can be full thickness, but they tend to be very wet and kind of become widespread around that area. Pulses are often palpable, but they're not always easy to palpate because of the amount of edema. If you palpate a pulse, we're going to work on palpating pulses today. We looked at pictures yesterday, dorsalis, pedis, and posterior tibial. A lot of times you have to sink your fingers in through that pitting edema in order to feel it. But usually you can feel them, especially on the dorsum of the foot, where it's fairly bony and you tend to be able to palpate them. So palpable pulses. The later signs are tissue changes. So you tend to get fibrosis, the thickened, woody-looking tissue that's all this buildup. Sometimes there's debris on it, especially if they're not very able to clean themselves. Things stick to their leg, and then more accumulates on the surface, and they become very crusty. Okay, so the early stages, and this is when, in my opinion, this is when somebody should be noticing the problem and educating the patient before they have wounds, before they have leaky tissue. I can't tell you how many times I've had a patient with venous wounds where we're managing and trying to heal that wound, and I'm educating them at that time about the venous system and what happens, and they'll say, well, this has been coming on for years, I've been dealing with it, and they never were educated. Either that or they didn't take it seriously. But we're in a prime position to be able to identify and educate people as to these things, and we can use photos to show them this is how things evolve, but this is the time you need to stop and make a change in your day-to-day habits so that you don't get wounds. Okay, so proximal medial malleolus, that's the most common place. This particular one's been being treated and had compression and exercise, so we'll talk about this one again later. Another one that has, again, been being treated, so you don't see the edema so much, but from a wound care perspective, you would want to evolve what you're doing with the patients as their wounds become less wet and you get the edema under more control. Okay, so let's talk about what do you do for venous patients? What can you do? I like the term optimize venous return, improve venous return, eliminate the underlying etiology, the underlying cause. That's going to help you kind of restore balance to the tissue and help good things happen. It's also going to keep them safe. Because when you think about it that way, you don't have such like that tunnel vision, that focus on one area of the body. You're looking more holistically, and that's going to give you your best outcome. So, to optimize venous return, many of the same things that we talk about when we talk about lymphedema are going to be mirrored here. You want to make sure that liquid has somewhere to go, because if you start thinking about pushing, then that's bad geography. You're moving that liquid from somewhere distal and it's moving proximal, but if it doesn't have somewhere to go. So I do like also the idea of thinking with your sound of the toilet flushing. And I will repeat that over and over again because it helps us remember, am I successful? Is this liquid actually leaving their body, or is it just being relocated somewhere else? So you want to start with the idea that they don't have contraindications, which we'll go into again. That'll be the last thing we cover today. And it should be really making sense because you'll understand we talked about it throughout the day. So breathing, nice deep breaths. That's going to help at your most deep vessels. So nice deep breath is going to help your heart pump better. It's going to act as suction. When you take a deep breath, that same suction that fills your lungs will also create suction in the deep vessels. So it's going to allow blood to fill in those deep veins and arteries. So your aorta and your vena cava it's going to give you suction when you breathe in, and when you breathe out, it's going to help empty them. So that's going to significantly increase blood flow. It's also going to help. I always think taking a deep breath, it's going to wake up your kidneys. It's going to circulate through your kidneys. It's going to help your digestive system. It's going to help things start going through their peristalsis. It's going to also move through your liver. So it's going to help increase your activity of blood flow within your core. Exercise. When you do the exercise, think cardiovascular. Doesn't have to be aggressive. You know, if they can get up and do what we think of as cardiovascular exercise, walking on a treadmill, using a bike or a new step or something that's going to really get your cardiovascular system going, great. But the challenge here is I would really rather it not be once a day or every 3 times a week. So when you think about cardiovascular exercise for the point of, improving overall fitness, you think of, 45 minutes of exercise multiple times a week in order to do that. Well, from this perspective, I'm thinking more, what can we do to get your cardiovascular system going a little bit? It doesn't necessarily, I'm not necessarily thinking of, the markers of, 80% of your resting heart, what's target heart rate. That's not so much what I'm thinking of. I'm thinking, what can we do throughout the day to optimize your cardiovascular flow? And so I'm going to find something, hopefully that they like to do, and that they can and are capable of doing several times a day. It may just be getting them to be able to get out of bed, move about, and even a wheelchair. It could be getting them to be able to stand and transfer. Something that's going to allow them to do these activities multiple times a day in order to get their heart rate flowing, because that's going to help with more persistent and ongoing cardiovascular flow in order to improve their edema. And then strengthening. If they're very weak, then we definitely want to think about strengthening, but instead of thinking about progressive resistive exercises where we're going to gauge it according to the 1 repetition maximum and make it challenging so the muscle hypertrophies, yes, that's great. That's a part of our rehab process anyway. That's wonderful. But I want to find something that they can do, again, just like the cardiovascular, throughout the day that they find easy enough that they can do to get that movement and do it repetitively. That's going to help with the blood flow. When you do these exercises, go from proximal to distal. Think about it as making space. Where do you want that liquid to go? A lot of times I use that example of, or an analogy of traffic patterns. If the highway's not up to speed and clear, relatively clear, then new liquid can't go. So get the highway up to speed. Make sure the highway is not overloaded and there's not high blood pressure already. So doing those exercises, clearing a path, is going to make the liquid flow much, much easier. So proximal to distal, some of it is simply just reversing what you've done in the past. I have a lot of people where, their daily habit or their repetitive technique with patients is they walk in the room and they say, pump your ankles, maybe then do a heel slide and then do a glute set. If those are the repertoire, I would reverse that. I would start with a glute set. I would start with a nice deep breath with every single patient all the time. Start with a really good deep breath. And many, many times I'm saying, is that as deep as you can do? Let's do better than that. I may put a tissue out and say, I need you to be able to fill your lungs and then blow on the tissue. And try to get them to be as aggressive as possible, because that's going to create that suction that's going to really get things going deep. And then I would do anything I'm going to do with the trunk, whatever I'm going to do with the pelvis, and then work my way down. That's going to be a better just overall habit. Many of my patients that are admitted, I actually have a file with Edema Protocol, and it's a handout with the exercises with a little picture and then the description. It's just much easier, and those of you who do a lot of treatment where patients have maybe post-orthopedic or any kind of issue where you're dealing with edema a lot, it makes your job easier if there's specific routines. And it has, the very first thing is a deep breath. It has, the core exercise where when you take a deep breath, you exhale and you tighten up your abs. You can print out a variety for some cognitively impaired patients, for the patient who is very with it, for the higher functioning patient, and then you just have it all ready to go. You can just hand them out. But from proximal to distal, it's going to be more effective. It's going to help edema move better, and it's just a safer way to do it, making sure it goes with ease. Elevation. I mean, gravity is our enemy here. And here's the challenge. If they can walk, I would rather they be walking than sitting or laying with their leg elevated. But, educating people is going to be important. So a lot of times when they're going through a period of edema, or if they have a chronic condition, and they're not capable of walking and moving all the time, they're just not healthy enough, and that's not going to be in the short term, it's not going to happen, then educate them. I talk to them about, when you're up, you better be doing something important, because I don't want to come by and see you sitting here watching TV with your legs down, because no, you better be pooping, peeing, eating, or doing something really socially awesome, visiting with somebody. If you're going to watch TV, or you're just going to be sitting there reading a book or something, you better have those legs up above your heart, because if not, we're not going to get better. You're not going to have that resolution. I remind them about whatever, if they have pets or grandkids or great-grandkids, I'll say, mirror them, do what they do. They're never just standing there or just sitting like you guys are. They are moving all the time. And when they sit down or rest, they're down. I mean, my dog's a good example. He's either up chasing something, or begging for something, or running around barking at something, or he's laying down. And that's really a good philosophy, because you're going to have that fight against gravity when you're sedentary and your legs are down. So educating is important. Now, external compression. We're going to talk about that a lot. And external compression is wonderful. It's a tremendous adjunct, but it's very, very possible that you do it wrong, you make matters worse. So this is the thing, is I think it can cause a false sense of security. I've had patients who said, oh, I'm not going to get a DVT. I've got these fancy stockings that they gave me in the hospital. So the false sense of security that somehow that's going to affect the amount of blood flowing through their venous system in a deep compartment, not realistic. What it's going to do is it's going to help blood go from the superficial compartment into the deep compartment, but it's really not going to do much for that deep compartment. And that's where a DVT is going to form, so that's what we want to be focused on as well. So external compression can be wonderful, it can be an adjunct, but you got to make sure you're using it in the big picture of things with a good overall plan of care. It's not a standalone. Lifestyle changes, I mean, these are always going to be important, especially in chronic venous patients, is talk to them from a human perspective, relate to them about weight loss, diet, exercise. A lot of times they have a very unhappy relationship with it because they've been in situations where they were in a physician's office or some other healthcare provider and they felt demeaned and disrespected. If they're overweight, they know they're overweight. They are probably embarrassed by it, or they've got a chip on their shoulder about it because they've been, so if we approach it from the standpoint of, what did you ever, was there anything you used to do for exercise that you really enjoyed, and how to come up with something that they will enjoy, even if it's they played football, and certainly you can't necessarily have them play football, but you can use sports and competitive and something sporty-like to incorporate something that they might enjoy more. And then smoking, there are many, many options out there. Many of them we can help with, but a lot more of them are medication related, physician working with them. If we can help from a friendly team effort standpoint that, we can do this, are you open to the idea? Always approach from a safe perspective. Otherwise, if you don't have a good rapport with the patient, it's less likely you're going to get really good compliance. So when we think about the venous system, there's the deep, and we think about what moves it. So the same philosophy that we went over yesterday. Start proximal, start deep. Think about where the blood's going to go, and then get it moving there first. So what moves it in the deep compartment is well, breathing, physical exercise, physical movement. Gravity can help, but when we're talking about the deep vessels in our core, gravity isn't going to play as much of a part, and that's where you, when you're thinking, okay, I'm going to start deep, I'm going to start proximal, that's going to force you to think about deep breaths, cardiovascular exercise, proximal to distal exercises. So looking at the deep vessels, they're in the fascial compartment, movement and exercise, that's going to be your key component. Superficial, this is where external compression can be helpful. Physical management can be helpful. So touching, moving, and what they wear can either be a benefit or it can be the enemy. I have a lot of little nicknames for myself, and I definitely am a wrinkle police person because the majority of our patients have compression on. I mean, if they have paralysis due to either brain injury or some sort of impairment due to brain injury, or they have paralysis due to spinal cord injury, they very, very high risk of pressure ulcers, DVTs, all of these same conditions as well. So compression is regularly used, but the problem is I see so many times they don't fit properly or they're not applied properly, and they can be causing more harm than good. So on the superficial compartment, compression can be wonderful and helping move this blood into the superficial vessels. But on the other hand, if it's on too tight and you have a wrinkle right here or a wrinkle right here, it can act as a dam. And so you can see how these vessels have to go past, they have to go past, but if there's a dam set up here, it's going to end up causing them to get even more swollen. So again, teaching people, and you're going to have to choose the recommended compression product based on safety. You're going to have to figure out what is reasonable to do, and sometimes you're not going to use compression because you think there's just not a way for me to know that they're going to be able to safely monitor it, especially in a home health type situation or an outpatient type situation. More home health than outpatient because the functioning is often less. A common problem here is that same idea, what's going to move it through the deep compartment is physical activity, movement, full range of motion, muscle contractions, breathing, certainly gravity. The more distal you are, the more effect gravity could have an effect on it. But when you're talking about up in the upper thigh area, gravity can still help, but it's not as effective as it is going to be for the area that can be higher. And then your superficial, same thing. Yes, touching and feeling can help, but external compression can be very powerful as long as it's put on right and it fits right. It's the proper application. It provides that sort of amount of pressure that graduates. Okay, so that was a little bit about venous, and then hopefully it'll all pull together. We'll talk about the mixed etiology. So many times the patients that come to us, it's not a straight up one problem. It's a mixed bag of things, and we want to address all of them as best we can. From an acute standpoint, what happened? They sprained their ankle, they had surgery, they had an open reduction in internal fixation. Whatever happened that lead them to you, and if they have acute edema, what are you going to do about it? And how can you try to resolve it and keep it from turning into a chronic condition? But then you have to look at underlying pathology as well. So if they have complicating factors, you want to take those into account. So acute, we just talked about this, and you've got the slowing of everything. Everything has been slowed down for a purpose. So you've got vasodilation and the permeability of the vessel increase, bringing all these solutes and liquid with it. You've got a lack of removal. The patient's in pain, they don't want to move. Really good example is a knee replacement patient. Hopefully they got some education ahead of time. Is that happening? Are they getting education ahead of time sometimes? Okay. So basically, if ahead of time they're kind of aware of the problems, and they should hopefully come out of surgery with compression on already, and elevation, and they should be off waiting to heal, and we want to get them moving as soon as possible. And the combination of edema management, pain management, and just overall looking at any complicating factors and paying close attention to them is going to be super powerful for getting them back. And I think, as we talked about in our conversations late yesterday, is sometimes somebody's got to be the leader of this to make sure this is all coming together, because we're kind of fragmented a lot of the time, and maybe the patient's not quite understanding the big picture because nobody's really taken the time to tell them. So it is kind of challenging. But from an acute perspective, if you eliminate the cause, which is the inflammation, you eliminate the edema. So it can be a very quick turnaround if you get some of that edema under control. The limb is lighter, it doesn't hurt as much, all of a sudden the range of motion is increased. And then it's this sort of tipping point where everything just starts evolving and coming around. So addressing the edema can be huge, and getting that program going. Education. I mean, I think I mentioned that already, but educating, giving handouts. A lot of times they hear, 25% of what you're actually saying, getting them to repeat it back to you. I definitely repeat things a lot, and I have them parrot it back to me. I have them demonstrate. I'll help them do something, and then I have them return demonstrate. Especially if you're in a situation where they have some medication related, not quite alert as they usually would be, they may already have some slight cognitive issues. It's not a fun place to be when you're hurting and you're in an acute situation. They're probably very worried about life in general, especially if it was an unexpected injury, and there's a lot of problems going on. So it's important to have them repeat back to you and return demonstrate everything that you're talking about. The time it takes to do that is well worth it to get good outcomes. Okay, so education. All right, so let's talk about compression. Compression, as I said, it's risky business. Compression that has elasticity, very risky business. You've got to be careful because more harm than can be caused than good. But it can be a powerful adjunct if you use it properly. So risk assessment. What is the etiology of the edema? If you can't answer that question, if you can't say this is why they're swollen, you shouldn't be doing anything with them, let alone compression. You need to figure out what's causing it. If it is venous and it's chronic, if it's acute, but they have underlying problems, knowing those underlying problems and looking at them and asking the patient, doing a good history and looking at their whatever provided medical history that you have can help you identify any kind of underlying problems that are going to be a barrier to improvement. Do they have adequate arterial flow? So yesterday we talked about you have the arterial system, the venous system, and the lymphatic system. And the arterial system, you don't want to rob from Peter to pay Paul, and the arterial system is Peter. So that's more important, because if you do anything to occlude or diminish the arterial flow, you're immediately robbing it of emergency situation. You're not getting enough oxygen and nutrients. So how is the arterial blood flow? Palpate fetal pulses, that's one method. Do I have pictures in here again? No, I don't have them in here again, but I had pictures up yesterday of the dorsalis pedis and posterior tibial. Palpate them both. If you can feel at least one of them, that's a good indication that their blood flow is adequate to be able to handle some compression. If I'm going to do high compression, if I'm ever going to do high compression bandaging, I'm going to make sure I get an ankle brachial index. Now, an ankle brachial index could be something that you have to request and have someone come do if it's in a facility, or it's something that maybe they can be sent out for, or they can go to the doctor to get done. But vascular testing is worth the effort in the event that this is going to be a complicating factor, because they could end up with serious problems and amputation if their arterial blood flow is not adequate. Ideally, that should be looked at ahead of time. If you have a patient that you're seeing and they're thinking about having elective surgery, and you see indications of arterial problems, recommend that they get assessed. Do you remember the different things that happen with poor arterial blood flow? What are some of the things you see? Lack of hair, so hairless, especially first on the toes, then top of the foot, then up the calf is an indication of poor arterial blood flow. Poor capillary refill. So you can squeeze at the nail bed, depending on their pigmentation. The nail bed is always a reliable place to go. They should have less than 3 seconds of capillary refill. The legs that get crampy when you either have them elevated or when you ambulate, so intermittent claudication. resting leg pain, so they say, oh, my legs cramp up at night, so I sleep with them in a declined position, maybe in an easy chair. Those are all indications of arterial blood flow issues that are red flags going off in your head that they're not going to be safe for compression. That would lead me to have them see a vascular doctor, because without adequate arterial flow, any problems that exist in that area are just going to be slower to heal, more likely to get complicated, and it's going to really limit whatever you can do to intervene to help that edema resolve. So an ankle brachial index, you basically take the arterial pressure in the ankle compared to the arterial pressure in the arm, and they should be the same. In the lab this afternoon, we'll do an ankle brachial index. You'll have a chance to do it on each other. It won't be exactly per directions, because it requires you to have the patient laying down for 10 to 15 minutes. You basically have them lay down in a relaxed position, comfortable, in a comfortable temperature room. So they're going to be laying there in order to get everything to even out and be more predictable. And then you take the blood pressure in their ankle, in their dorsalis pedis and their posterior tibial, take the higher of the two, and then you get it in their arm, both arms, and take the higher of the two. And then you divide what you get from the ankle by the one you get from the arm, and then that should be 1. So I'm not great at math, but let's say you get 80 millimeters of mercury pressure at the ankle and 100 at the arm. You divide 80 by 100, you've got 0.8. That's going to be your cutoff for most products. So a lot of products will say contraindicated with ankle brachial index of 0.8 or lower. Or it may say, you know, this, you could use this product conservatively with good monitoring, but for the most part, the lower the ABI, the less likely, first of all, they're going to heal. It's going to be making life more difficult because of arterial problems, and so even if you're not going to do compression, they still should see a vascular doctor, because it's something that's going to be a problem for them lifelong, and they've got to change something about why this happened in order to not let it get worse, because that's going to end up being wounds and amputations down the road, especially when you combine it with a mixed etiology. So,
so you're looking at the diastolic or the systolic?
You're looking at the systolic, only the systolic. So you're getting the highest pressure. And to do it, I use a Doppler. So I use a Doppler, and that is the recommended way, because when you think about getting a blood pressure, just taking a normal day-to-day blood pressure, the first pulse you hear, so basically you pump it up until there's no pulsing, and you exceeded the pressure in that artery, and then you start letting it out. The problem is with a stethoscope, you don't actually hear the pulsing until you pumped it up. You know what I mean? So when you're just listening when you're at rest, and then you pump it up and you slowly let it out, when you hear that first one, it's possibly not as accurate as it would be if you use a Doppler. So with a Doppler, you already know you're on the spot. You're hearing the pulsing already. You pump it up until you don't hear it for 2 beats, and then you slowly let the air out. And as you slowly let it out, when you hear that first one, you're done. The test is over. So that's all you need, is the highest pressure in the vessel. So once you know what the highest pressure in the ankle vessel is, you can compare it to the highest pressure in the arm vessel, and it should be in the same, it should be right around 1. If it's falsely elevated, you know, so if you think about somebody who has, say, a very large limb, so they could have be a person of size and they've got a lot of edema, the bigger the limb, the harder it is to get a reliable result. And so if I have a patient who's quite large, well, first of all, you need a bigger cuff. The cuff, when I use a cuff, I usually say the width of the cuff should be at least the width of the limb. So meaning like this, that width of the cuff should be at least the width of my limb. It's kind of a physics principle. So if you're looking at a leg and that width is not wider than their ankle, you'll need a bariatric cuff. When you need a bariatric cuff, if it's still, that's going to decrease the reliability of it and the likelihood you can actually cut off the circulation. Because the larger the limb, the harder it is to impair and cut off that blood flow. So you may have someone where this very simple bedside test is not a reasonable option because of their size. So you may have to send them out or request a more advanced test be done because, you know, as people get more complicated, the testing becomes more complicated. It's harder to diagnose accurately. So there's another condition that can be a problem, which is calcified vessels. So if somebody's had diabetes for a period of time, they could have calcified vessels, and those vessels can be very difficult to compress. And so what can happen is you could get a false high level in the leg and think that they have good blood flow, but they actually don't. So levels that are above, say, 1.1, 1.2 should start raising red flags in your mind and say, wait, that doesn't seem likely. So the combination of things is going to cause you to want to get more advanced testing done. So a level of 1 is typically what you want to get, but you also want to be looking at the other characteristics. So the combination of your ankle brachial index, your history and your assessment, looking for the hair on the toes, sensation, all these kinds of things coming together is going to give you the big picture. So just one thing alone is not enough to help to give you the big picture. You've got to look at all the characteristics together. Okay, so that's the idea of ankle brachial index. They need to have adequate skin condition. So if the skin is very fragile, you know, you have people who maybe have steroid skin, they tear easily. You walk in their room and you see they've got skin tears all over them, they're bruised all over the place. You're going to have to think benefit risk. You know, if they have edema in their lower legs and the benefit of some compression outweighs the risk of increasing maybe some bruising, you're going to have to look at that because there's all different degrees. You have people who are just a mess. The skin is in horrible condition and it bruises easily, tears easily, versus some people who, yeah, it's not in the best of shape, but the reduction of edema is going to be of such benefit that it's going to outweigh the risk of possibly having them, you know, rub themselves or have a little bit of something that might happen where they might bruise in one part or another. So that's where the big debate is going to come in. Do they have good sensation? I mean, that's super important. So if they have a combination etiology, they maybe have some venous problems, but they also have diabetes, you should be testing their sensation. So testing their sensation with monofilaments is the most reliable. I have some monofilaments, I'll pull them out on the break. But basically testing their sensation, because you could wrap somebody and if you're exceeding the pressure, it should hurt, but they may not have the capacity to tell you it hurts because there's sensory impairment. So diagnosis of diabetes, even if they're not diagnosed with diabetes, check their sensation, make sure the sensation is present and adequate to keep them safe. Cardiac stability. If you compress somebody, it's going to be trying to push liquid in. I mean, that's, even though we don't like the idea of pushing, that's essentially what you're doing is pushing it into the superficial capillaries, blood capillaries, in order to hopefully get it further into the deep vessels and then into their main circulation. If they don't have good cardiac stability, maybe they have congestive heart failure. Maybe a history of congestive heart failure may not be a stop sign, but it's a yield sign. If they have active congestive heart failure, it's a stop sign. That's not going to be appropriate until you can get their cardiac situation under control. You can work with their physician. You can maybe work together as a team where they're diuresing them. You can get some improvement. You use their blood pressure as a marker as well, and their weight, and you can work with the medical team to try to do it, but it's going to be much slower and careful. The more edema they have, the more cautious you need to be. The condition of the limb. So could they have a DVT? So you want to assess the limb and think about if they have a DVT, you're not going to do compression until you're cleared by the physician. I mean, very often they will want you to start compression, but they want to start. Every patient's slightly different, and depending on what kind of medications they have in their body, the physician's going to help you decide based on the coagulation levels. And so this is something that's not our decision to make. We work with the medical team. So talk to the doctor about when is it appropriate to start exercise and compression, because the times have changed. I mean, when I first got out of school, everybody was in bed. If they had a DVT, they went to bed, and you didn't move them until they got the anticoagulants. But now, I mean, in our perfect world, we should see the risk factors ahead of time and prevent the DVTs as best we can. And I know in my situation, it's a lot It's a lot better. The effort is there. It doesn't always get done. I mean, intention is there, but it's not always done routinely the way it should be. But I do think we have made some significant headway, but it's not always consistent, and it doesn't always get the level of importance it should have. But preventing DVTs is crucial. Once they have one, doctors are much more aggressive than they used to be. You get them to coagulation levels that are safe, and then you get them exercising, moving, and compressed. Infection. Some products will have labeling that says contraindicated in the situation of infection, if they have infection. Communicate with the physician, because just because they had an infection, what type of infection do they have? And at this point, they're on whatever the appropriate antimicrobial, whether it's oral, IV, whether it's topical. You can talk to the physician and say, at what point is it approved for me to go in there? Because if they're on, think about somebody who has a lot of edema. They're very swollen. Things aren't moving very well in and out of there. Are the antibiotics that they're taking maybe orally doing their job? I mean, that's the frustrating part about it. They're getting all kinds of side effects, but the idea that getting to where it needs to go is impaired by the situation with the edema. So this is where you talk to the physician, you talk about the timing after they're on the appropriate medication, and the markers that you're looking at. Because infection is not like you have it today, it's gone tomorrow. It's not a black and white thing. It's how many organisms, where are they, what's causing them, where they come from, where's the source, and then working together as a team to decide the best overall way to resolve it. And sometimes compression is a big part of that, and it can help resolve it faster. It certainly can help prevent it. So ideally, we want to be treating the edema as soon as possible and prevent the infection from occurring. So some methods that we're going to talk about. We'll talk about compression bandaging, which is more labor intensive, but it's a custom product that fits them every day. So every time you wrap them, you've created a custom perfect fit for them. Compression garments, pros and cons. Well, garments, you do want them to fit properly. They're much easier to put on. And many times then other healthcare providers, loved ones, the patient themselves can put it on, and it's much less labor intensive. But they have to fit right. They have to be used appropriately. They have to be able to put them on, because sometimes they can be quite challenging to put on. So garments can be appropriate, but they're also not great when the person fluctuates. So you may have someone who fluctuates so much that the stockings that fit on this day aren't going to fit on that day, and so they may need to look at some sort of alternative method. Bandaging is often a great thing, but it may not be something they're going to comply with forever. It's just too much work. So we'll talk about some different compression alternatives that might be useful and appropriate, and they may be able to comply with them. And intermittent pneumatic compression, it's not my favorite thing to talk about because it means passive. It means that patient's going to have to just kind of let a machine do the job, which is not ideal, but sometimes it's appropriate. I mean, when the patient can't move, they're incapable of moving, there's nobody that can provide the care that they need, and therefore that's going to at least help them maybe get improved, and it could be a means to an end where it improves their situation and therefore they start moving better. Okay, so I had talked about testing sensation, and given the fact that diabetes is such a huge problem in society right now, and not even just with older people, we're seeing it more and more in younger folks. It's important to be able to test everybody's sensation. There's a program that's called the LEAP program, L-E-A-P. It stands for Lower Extremity Amputation Prevention. It's a government-funded program. You can actually go online and order. You can get one of these for free. It's basically a starter pack of monofilaments. I think it's like a dozen. Yeah, so I think it's about a dozen of them. Basically, it's these individual monofilaments. It shows you a little picture. The paperwork comes with it telling you how, the accompanying paperwork that you could utilize if you wanted. There's handouts you can provide patients. So anybody who, I really think this is a great thing for outpatient clinics or anybody who wants to host educational programs. But basically, to use the monofilament, you place it on the plantar surface of their foot on each indicated area. So it indicates the areas on the little handle. You push. By the time this bends, that's 10 grams of pressure. They should feel it. If they don't feel it, you mark it as impaired sensation, and check each spot that it marks. And then you educate, because the problem is that lack of sensation isn't really, there's nothing that we know now that is going to permanently correct that sensory loss, and so they're at tremendous risk, but they really need to turn it around. It's an educational need that if you don't turn it around, that's the #1 cause of amputation in our country is diabetic-related neuropathy. So education, but also for your own safety, that you're looking at footwear, you're looking at exercise methods that are not going to hopefully cause pressure ulcers and things of that nature, because they're at such high risk, that you're choosing your compression products accordingly in order to keep them safe, and that if they have this sort of mixed etiology, you're going to probably not be able to do an ankle breakthrough index yourself, or even palpating pulses may not be as reliable because of that possibility of calcified vessels. So having a combination of diabetes and some neuropathic changes would lead me to want to make sure they've been worked up well by a physician, and that they understand the magnitude of it. Because sometimes it's getting them to buy into the magnitude of how serious this is can make all the difference in the world for compliance. Okay, because sometimes, if it doesn't hurt, I can't be doing anything wrong, right? There's no pain, but it's important. I mean, your story yesterday about you can't go skating because of the pain. If you didn't feel the pain because of a sensory neuropathy, and you kept doing the offending behavior, which is what they do, they put shoes on, they walk a certain way, they bear weight, they rub themselves raw, and things like that happen quite frequently, and they don't see it coming because they have the neuropathic sensory loss. Okay, so moving on and talking about compression again. I love this picture. I really should post it everywhere because, and that's what I'll sometimes tell people is if you wrap somebody's legs and you compress and it doesn't have anywhere to go, that is what you're doing. You're going to pop their eyeballs out. I mean, that's an exaggeration. But the reality is, if you're trying to push liquid somewhere that it doesn't have room to go and it's not going to exit, it's going to relocate. And it may it's going to relocate somewhere worse, because more proximal edema is worse than distal edema. It has more severe health ramifications. So make sure it has an exit. How tight do you want it to be? There are tools. I've got one over here it's basically a document. There's a number of organizations that have come up with documents that are guidance as to how to choose and apply compression. The challenge there is if what's recommended is not tolerable, or it's not feasible for them to don it themselves to be compliant, then I would go for whatever is the most appropriate thing they can use. 10 to 15 it's typically what you're going to see in a TED hose, when you talk about TED hose. But even TED hose, even a product that's labeled and it says 10 to 15 millimeters of mercury, if you don't size it adequately, and a lot of times when you look at the back of it, it'll tell you the centimeters of circumference that it's appropriate for. If they're at the lower end or the higher end, that's clearly going to cause changes in the level of compression. So all of these are not an exact science. And
so how do you measure it though?
How do you measure?
Like the circumference, like do you measure it when you have the most swelling or the least?
Usually it has you measure the ankle and the calf. And so when I do measurements, I measure the smallest part of the ankle and the widest part of the calf. That is just by far the most reliable. Trying to measure somebody, and I've got a couple of different tape measures here so we can practice during the lab measuring, but trying to measure at key places is, if you look at the inter-rater reliability of you and I both trying to measure somebody every inch along their calf, there's a significant amount of inter-rater reliability problems, and the angle you go is different. So the most reliable that you can get is the smallest part of the ankle, because it's very easy to slide up and down and find the spot that's the smallest. And then it's pretty easy again to slide up and down and find the spot around the calf that's the widest.
But it will be lesser in the morning versus at night.
Yeah. Well, the challenge there is to find a steady state. And so the question being, what do? They're worse at night than they are in the morning, they're bigger. I would take that morning measurement and get the stockings on before they get up. And what's happening during the day that's making them more edematous? I mean, are they sedentary? Are they just sitting? Then we got to change those habits. And that's actually a good outcome measurement. That's a good goal to set, is that your edema will not fluctuate during the day, that it will not be greater than whatever you determine, a couple of millimeters, whether it's a centimeter, whatever they're fluctuating now, if it's several centimeters, that you could set a goal for it to fluctuate 50% of that or less as one of your goals to show compliance, that they're using all the strategies you're giving them. Because fluctuating is not good. I mean, when you talk to them about your legs getting bigger and smaller every day, is actually worse than just having steady state and just staying this way. And so we need to come up with a plan that's going to be a achievable size, that's going to be your steady state, and then we're going to get you into stockings that fit you for that size, that you can comply with. So it's a challenge, but it's the best idea to figure out. If you measure them at their absolute smallest, and you've been treating them and they've been really compliant, and you get them in these stockings that are required for them to be a certain size, but then as therapy discontinues, they all of a sudden aren't quite as perfect and compliant as they were and they can't get their stockings on. You should educate them as, if your stockings are hard to don one day, all of a sudden you wake up and you're trying to put them on as normal and they're tighter and they're harder to get on, that you have some sort of a solution there. Because if that happens and they just abort and stop using them, they're back where they started again. So again, it is a good measure of compliance. It's a good measure for them. Okay, so the 10 to 15, very common label of your product, realizing that that's not necessarily going to be how much anything on their label of any device doesn't necessarily mean that's exactly how much it's going to provide them, because it's all dependent on them being the same shape as the research study that they did, and everybody has a slightly different shape. Okay, I got the message about the monofilaments. I'll touch on that in a second. So basically 15 to 20 is a very typical level. It's not super tight, but as you go up from there and you go higher and higher on the level of compression, they become more rigid. In order to offer that much compression, it means you can't stretch them. I mean, they're really hard to stretch. And I don't know, I've read in documents where they recommend like 40 to 50 millimeters of mercury. I don't know who on earth is putting these things on, because they are really not stretchy at all. So I can maybe put that much on somebody with wrapping, because I can use that tension and wrap, but to try to slide it up on their leg is going to be really, really challenging. And if they have any kind of pain, or if they have any kind of weakness or range of motion deficits, it's going to be nearly impossible for them to get them on. So when you look at these different recommendations, you also have to be realistic about whether they're going to be able to use, whether they're going to comply with. And sometimes I'm going to go with the one that is lighter. So a lot of times I'm going with something in these ranges simply because they're going to comply with it. They're going to be easier to get them on. They're going to allow some flexibility so that they can actually do their exercises and move. Because if you put too much compression on somebody or too much bulk, and you now decrease their voluntary range of motion, you've just done more harm than good. Because I would rather you have activity, physical movement, and less compression if I'm given those two choices. So the level of millimeters of mercury, take it with a grain of salt. And when you're reading these documents, look at the big picture of things. And I still, number one, want people to be able to do exercise and movement and walking and get them on. So someone online was asking for how do you get the monofilaments. The website, it's called the LEAP program, L-E-A-P, Lower Extremity Amputation Prevention. And when you go on there, there's a number of handouts, and then there's this spot with a drop-down menu where you can order things, and they will have a starter set of monofilaments. Sometimes I'll go on there and people will tell me they were on back order. If that's the case, there are places you can buy them as well for just several dollars for a small pack of them. So they're pretty inexpensive. And I think it's a really good marketing tool as well if you wanted to market your clinic, or if there's an awareness program that you want to offer. That's a great one, and it might generate a caseload as well. Okay, so thinking about the classification of how much compression you're using, and now think about what types of product you're going to use. So compression bandaging, you want to think about the bandage characteristics. And let me see what slide's next. So I can come back. Yeah, so we'll talk a little more about bandage material. So the bandage characteristics, this is typically what the bandage is made up of. Is it elastic? Is it more inelastic? Is it thick, padded? Is it hot? You know, a lot of patients will complain that they're bulky, that they're hot, they can't wear their shoes. So you want to think about the characteristics, and we'll go through a variety of different products and why some characteristics are good for certain things but not good for other things. Limb characteristics, you know, the size of the limb, the bigger the limb, the wider and bigger the circumference, the less effective any compression is going to be. When you think about hugging a tree, you know, if you think about putting your arms around something and trying to squeeze, the bigger it is, the harder it is, and the less compression you're going to get. The smaller the limb, the more risk of harm. And so finger wrapping and toe wrapping is potentially dangerous. They're so small, just a little bit of compression is too much. You've all probably put a Band-Aid on your finger before, or tape or something, and your finger turns blue. So it's extremely easy to occlude over an area of small dimensions. So when we start looking at the application and how you apply a bandage, small areas with a circumference wrap, dangerous. You know, larger areas can handle circumference wraps, but smaller areas or mobile areas like a joint space, you would not want to wrap in a circumference. And you know, if you've ever given blood or had blood drawn and then they put a piece of tape around it with a little cotton ball, and you go to bend your arm, you can't bend your arm. That's the idea. Anything that's mobile, if you wrap it with a circumference, the potential for it to be occlusive and cause a tourniquet effect is too great. So you're always going to wrap in a different style, in more of a, I call it a figure of 8. Some people call it a herringbone basket weave, but basically you do it in a way that's not as apt. You know, you still can have an occlusion, but it's not as likely. So no circumference wrapping over small areas or over joint spaces. So the size of the limb, the bigger it is, you know, you still have potential risk, and the less effective your bandage is. But if you wrap somebody with a large limb and a lot of edema, the problem you have there is there's a lot of pitting edema, and the pitting is pretty deep. When you wrap somebody, the potential is there that bandage sinks in and becomes a tourniquet itself. So the chances of it giving focal pressure instead of a nice uniform pressure, that risk is there. So you want to try to make sure you're wrapping in a way that gives nice uniformity rather than any place where it could accidentally come in and get too much pressure and sink in to become occlusive or like a tourniquet. The shape of the limb, everybody's not textbook anatomically the same, and so the wrapping products are designed to wrap somebody with a normal limb. What's normal? I mean, a typical, where it's narrow at the ankle and it's very slowly progresses wider. Well, a lot of times your patients are going to have these unusual shapes to them, and that's going to cause automatically a non-uniform wrap. And so you're going to have to be more cautious. The less uniform and the less gradual the circumference changes are, the more careful you're going to have to be. Bony prominences are basically areas where there could be focal pressure, and they could end up with skin breakdown, pressure injuries, and so you're going to have to take caution and use methods of wrapping that are going to protect those areas. When we talk about application, the typical breakdown is spiral versus figure of 8 or basket weave type thing. And so when we do the lab, we're going to practice both. When you just think about the application process, spiral, it's certainly easier. I mean, spiraling up someone's limb is going to make it go a lot faster. It's going to use less bandage, and it's just simply easier. But it's never going to be as effective and safe as if you do more of the figure of 8. So a figure of 8 is going to give you, it's going to require more bandage. So on a negative side, requires more bandage, requires more skill. It's a little bulkier, it's going to be a thicker wrap, but it also gives you a much more smooth, uniform outcome, lower risk of any kind of occlusion or tourniquet effect. So it's definitely better in some ways, but if you have a patient who their loved one or they themselves are going to be rewrapping at times when on their own, can they do it? Are they going to be able to do it? Are they going to comply with it? Or is it too challenging? And so sometimes your choices are limited based on their abilities and the availability of other people to be able to assist them. And then a really big important thing is how much physical activity are they capable of doing? Are they ambulatory? If it's leg edema, the question is, are they ambulatory? Can they walk and will they walk? That's going to make a huge difference in what you choose in order to capitalize on functional mobility. Okay, so when you think of what the term graduated compression, there's basically Laplace's law or law of Laplace. It basically means that, there's an inverse relationship between the surface tension and the radius. So the bigger the radius, the less the tension. And so if you have a I don't like that term, but if you have a typical shaped limb, if this is your calf, if that's what your calf looks like, and your ankle is the most narrow place, and then it progressively gets wider, you can wrap with the exact same amount of tension all the way up. So if I wrap, and I use a product that has some, it has some elasticity to it, if I use the same amount of stretch and tension all the way up the limb, I automatically have graduated compression because it's naturally going to be tighter, like a more narrow area. It's going to progressively get less and less. Now, if they don't have that natural shape and they aren't graduated, so let's say it's more of a tree, a trunk shape, it's just polymer. The problem is if I wrap with the same amount of tension all the way up, I'm not really getting any kind of a graduation. It's equally tight at the bottom as it is at the top. And so the potential is there, much more potential for either possible harm or just not as effective. So if this was the case, the question would be, can you change the shape of it? So what you might need to do is, if you can't make this more narrow, if that's not realistic, then you can build up with padding. So you can take padding and you can make it progressively thicker and thicker as you go up. Well, that's frustrating because it's already less effective on a large limb. And a lot of times they feel bulky and they feel weighed down and hot when you put compression on. Adding more padding is going to make it even more so. But that may be your only choice in order to get the edema under control. Once they reach a good steady state and you get their limb size down, then you can readjust and see, are they now a little more graduated because the edema was primarily down here? And if they now are graduated, you can measure again in a good compression product, or they may need something custom. And so a custom product is going to cost more, it's going to take longer to get it, but that might be what they need if they have a unique shape about them. So the less uniform they are, the more custom you have to be in the product they're going to use, or the application process. Okay, so thinking about compression bandages. A big breakdown is non-elastic or elastic. Now, those of you here have some products on your table. So the non-elastic ones is the Comprolon. So if you take the red, white, and blue one, the Comprolon, and go ahead and open it. So basically, this is your non-elastic short stretch. So you can see that it changes shape a little. It gets a little bit longer when I pull on it, but that's not because of elastic fibers. It's the way it's woven. So basically, it doesn't have any rebound. There's no elasticity. If I wrap you with this, it's going to be it's like those perfect jeans that fit you perfect, but you can't move once you put them on because they don't have any elasticity to them. So this is going to give you that custom fit, but it's not going to allow any stretch to it, and it's not going to give you any actual compression if you're not moving. So that's non-elastic. And then the other product you have is, well, I'm using it, this one's Cetapress, but that one's, you have Shore Press, they're the same company. But basically, these are elastic products. So they have rebound. You let go, you stretch them, they rebound. So they're elastic. These are different than an ACE bandage. So these products are labeled as high compression bandages. If you wrap somebody with this tension, it's going to give you a higher level. Now, the amount of compression they get is dependent on their circumference. So thinking back to that, Laplace's law, the wider the limb, the less compression they're going to get. The more narrow the limb, the more compression. So one of the contraindications to high compression bandages is too narrow an ankle. So pretty much everybody in this room is probably contraindicated for being wrapped per directions with one of these, simply because they're so big. Because their ankle is so narrow, it's going to be too tight, and it can occlude the blood vessels and limit blood flow rather than encouraging it. It'll still encourage venous return, but then you've got that robbing from Peter to pay Paul. It's too tight to allow arterial flow to get through that joint. So the elasticity is there. So how are these different than, say, an ACE bandage that you buy at the store? Well, an ACE bandage is going to give you about, they mark it as like 10 to 15 millimeters of tetos. So basically, the amount of pull, the tension that you have to use to pull on it is less. So yes, there is elasticity, but you don't have to pull this much. The rebound isn't as high. So this one, you wrap somebody with it at the same amount of stretch as an ACE bandage, is going to be significantly tighter than an ACE bandage would be. Okay, so that's the elasticity. Now, when you think about using the different types of bandage, I have elastic here first. So basically, elastic or long stretch bandages, you pull it, usually they're described as being wrapped with 50% stretch and 50% overlap, but we'll go into the different products. When you wrap, it's going to be tight. So I wrap you with it while it's on stretch. It's at all times when it's wrapped around you, it's going to be trying to return to its normal length, and so it's going to squeeze. So that's considered resting pressure. So because you're wrapped and it's tight, that's categorized as high resting pressure. Now, what happens is when you go to move, so basically work, when you go to move, you go to take a step. So I wrap your leg with this. At all times it feels tight. It's snug. But when you go to walk and you take a step, it stretches. So it's going to be able to stretch and allow you to move. When you take a step, because it allows you to move, it's classified as having low working pressure. Now, if you wrap somebody with something like this, and they're capable of walking, or they're capable of doing an ankle pump, you still want them to do it. That's still going to be an advantage. So you want them to be able to put in the work. That will increase the force that's created by this, but not as much as something that's not elastic. So basically, you still want them to exercise, but the difference between the pressure when they're at rest and the pressure when they're moving is not as big. Make sense? Okay, now say you wrap them with a non-elastic bandage. So with a Comperline type product, anything that's not elastic, when you wrap them with it, it's at rest not going to feel tight. So you probably all had some outfit. You know, the shirts that you buy, like the original polos or something, where they have no elasticity. We're very spoiled these days. Everything stretches, right? I almost can't handle putting clothes on now that don't stretch because we're so used to it, we're so spoiled. If I order scrubs on sale and the scrubs come in and all of a sudden I'm like, well, no wonder they were on sale. You can't move, they don't stretch. But they often look good, and they custom fit, they look fantastic, you know, you can't move once you put them on. So that's the idea with this. You wrap somebody with it in a good position, so maybe having their ankle at 90, you wrap them, and it's comfortable. So when they're in that position, it feels okay. There's really very low pressure. And so there's low resting pressure. Now what happens is when you try to do the work, so you try to walk, they go to take a step, and yeah, it gets tight. It gives you this inward force. So basically they attempt to move, and ideally they move in a way that's really full range of motion, good, nice step. It's going to pull in all different directions with every angle of movement, and it's going to give this pressure and force. The calf also shortens. Your muscles, when they activate, are going to shorten and widen, but they're going to be resisted, and that's going to help push the inward force. So the combination of the pressure going on inside the fascial compartment with the combination of external forces is going to help increase that pressure. Okay, so it's described as low resting pressure and high working pressure. Because it's low resting pressure, they're just more comfortable. It is just simply more comfortable because when you stop and rest, it just kind of feels better. And when you think about a gait cycle, so you're encouraging people to walk as much as possible. Now, this is the kind of person where you say, when your legs are down, I want you to be moving. If they're in a wheelchair, they should be propelling or rocking back and forth as far as they can, or on their feet taking a walk. Walk is take steps. I don't want you just standing there. I want you taking steps, at least weight shifting or walking down the hall. So when they walk, it's this constant pump. And when you think about what makes a good pump, high pressure followed by very low pressure. The same as what our heart, the best stroke volume of your heart is one that empties fully and then refills all the way. Empties fully, refills all the way. And that's exactly what we want in all their veins, is we want them to be emptying completely and then allowing it to fill back up again, empty completely, fill back up again. So the best idea there would be an ambulatory person with a non-elastic short stretch bandage. That would be ideal. So why don't we use this on everybody? Well, because they don't have work. They can't work. You know what I mean? So if I wrap somebody with this, and they are either non-compliant and they could walk, but they don't. They could exercise, but they don't. Or they can't. They're incapable of walking. Maybe they have some paralysis. Maybe they have, so some people may be reading the labeling and saying, oh, this is the product because it's labeled as being more advantageous, more comfortable, so they want to use it. But if they don't do some sort of physical work, they get no compression at all. So a lot of times we have to start out with something more elastic. And there are combination products as well. Let me see what my next slide is here. Yeah, okay. So let me just give a couple pictures. So this picture is someone who was using non-elastic bandaging. And just kind of look at the skin and you see how there's really no dents or ridges or anything like that. Versus this person was with more of an elastic type bandage. So you can see kind of ridges and dents. You can see them waffling of the skin. But these people don't have much edema. Yes, let me go back. So they have limited edema. If you have somebody with a lot of pitting edema, you touch them various places on the area you're treating and you're going to wrap, and they have pitting, you're going to see significant ridges and dents, and it can be itchy and uncomfortable. But when you wrap with elastic, you have these, every place where it's a little bit tighter than right next to it, they're going to get dents. Under padding can help. So using a padding layer can help prevent some of those little dents. The big enemy would be big dents, and something that could act like a tourniquet. And those tend to happen over the most narrow area. So if you wrap it, and then they start doing some exercises or walking, or you get them out of bed, somebody gets them out of bed and puts them in a wheelchair and their feet are dorsiflexed on foot plates, a lot of times they'll get a big old dent in the front of their ankle because there's focal pressure there. So if somebody's wrapped while their ankle is, in a state of plantar flexion, and then you sit them up and their foot is dorsiflexed, all of a sudden they've got this bulk on the front of the ankle, and that's problematic. So there's a number of things that can be a problem with elastic bandages. But sometimes it's our only option. You just have to really do a good safety assessment first to make sure they're good candidates. When you read the different product instructions, and you need to follow them, assuming they have specific instructions, and a lot of times your elastic bandages will. So many of the elastic bandages will tell you to wrap with 50% stretch and 50% overlap, or they'll give you a guide. So this particular product has a guide on it. And so there's a green box and a brown box. And if you read the labeling, it'll tell you for the amount of compression you're looking for, whether it's higher level compression or lower level compression, and the dimensions of the limb, it'll recommend whichever box you're going to use. And it'll say your stretch should be until the rectangle becomes a square. So the reality is it's meant to give you some sort of guidance on how to wrap. So some products, they will have a guide, and these guides are generally right at the 50% overlap. So it'll tell you to wrap, and then when you overlap, which side's darker? This side's darker. When you overlap, you're going to cover exactly to the edge of the box, and that's going to give you your 50% overlap. So some products, at very specific labeling, it'll tell you exactly how to wrap the foot, and then and the ankle, and then how to progress up the leg, whether it's a spiral or a figure of 8. And it'll give you guide as to show you how much tension to produce. Now some of them won't. So another example would be something like this. So this is an elastic bandage, but it doesn't have any kind of a guide as to how hard to pull and how much tension, but it has a line. So all of your elastic bandages should have some sort of a line or a guide on them. And so, for example, this product, it's a part of a multi-layer bandage, but you can buy individual ones as well. And it says you should wrap with 50% stretch and 50% overlap. So instead of giving you boxes and, some of them have like a little oval that when you reach the tension they want you to have, it'll have an oval with a little X in it, and that X becomes a perfect X, and that oval becomes a circle. So they often give you these guides, but I'll be honest, sometimes when you stretch them, instead of it being a perfect circle, it's kind of offset, because they aren't always perfect. And your rectangle doesn't always become a perfect square as much as a sort of crooked kind of looking thing. So we'll practice with some of this wrapping this afternoon. And you'll see they're not all exactly perfectly set up. But something that has just a line on it, if it's 50% stretch, then what that means is, for the amount here, if that's 100, meaning I'm locked out here, I can't stretch anymore, then I go halfway. You can be really anal about it. You can put a measuring tool out, and you can say, okay, that's 100% stretch. That's 50, 100, 50, 150, close your eyes, 150, get that proprioception going, get the feel of it, and then as you wrap, you try to stick with that same amount of tension. But without the guide, it's not, you're gonna have to go by feel and how much tension it feels like you're producing. What you never ever wanna do is take a compression product that's elastic and lock it out, meaning you wrap somebody at full elasticity. Any product, whether it's an ACE bandage over the counter or anything else. So when you think about the best pumps that you could possibly have, they're the pumps that have the biggest distance between the resting pressure and the working pressure. Well, the problem that you have with a locked out bandage is it's tight when you're at rest and it's tight when you move. It's just tight all the time. You never have any kind of fill phase. And the risk of damaging and harming is too great. So never lock anything out. Typically the 50% stretch is the highest you ever want to go. If you're not getting good results, then you need a product that gives more tension, where the 50% is tighter, but you don't want to exceed that 50% tension, because then the risk of locking out and not allowing any movement is too great. Does that make sense? Okay. Okay, so what you've been looking at so far, what we've been talking about, is single layer bandages. So single layer bandages, read the package material. There's a lot of different products available, a lot of variances between how much tension they produce, and then there are multi-layer products that we'll talk about that have mixed non-elastic versus elastic together, where you combine them. So you want to read each product separately and read the instructions. But there is certainly the possibility that you can combine products, but you have to be very careful. So what you don't want to do is take two products that are elastic and layer them on top of each other without running the risk of possibly exceeding the safe level of compression. So if you are going to combine things, think about what each level does, because any kind of elastic compression is going to summate with every subsequent layer. So let's say you use a high compression bandage, and you wrap the patient according to their instructions, and you find that it's slipping all the time. They get slippage, and so you end up putting a tubular elastic bandage on top of it. The problem you have there is the combination of this level of compression with whatever else you put on it could potentially cross the limit of how much is safe. So more and more risk with every elastic layer. Okay, so these are all single layer. With the majority of them, the instructions will say either you must use a padding layer, or it'll say you can use a padding layer. So sometimes it's optional, sometimes it's highly recommended, and sometimes it's the clinician's preference. So if you do have to use a pad, or if they're having little dents that are causing some areas of friction, it may be causing areas of uneven pressure where there's a bony prominence. If they're being really compliant and they're pumping their feet all the time and they're getting rubbed raw on the front of their ankle or the malleoli, then you can use padding. You can use padding in like a stirrup around the malleoli, or you could use it around the limb in general. So there's a variety of different padding products. A very typical one is something like this particular one is Artiflex, and a number of people make similar products. Looks a lot like cast padding or something like that. So they're more of a loose, non-woven, so you can just pull pieces off. It means it's not super, they can produce some tension. But what you can use it for is you could cut pieces off and create, this particular one was a little bit different too. So I don't know if it's gonna let me, these scissors are kind of terrible. I forgot my good ones. Okay, I'll do it later. But basically, let me just get rid of that end. You could use this as padding. So you could wrap the entire limb. You could build up thicker, wrap it even thicker in some layers. So this is not, you don't want it to be tight. You want it to be very loose. It's not going to look super pretty, but you don't want any focal pressure. This is something you could use pieces of it. You can create little areas that might go on the front of the ankle to allow less friction. You could use something, whether it's directly over the malleoli, or you could create something that would be a build-up to make it like a stirrup kind of thing. So this type of padding can be used, it's only limited by your own creativity. If you are going to do kind of a wrapping thing, keep having them move their ankle at the same time. So assuming we're going from the base of the toes up to the below the knee, as you're wrapping, have them move the foot up and down and see if there's any areas that you feel are going to rub. And then what you can do is, if it's wrapped around, you literally just can rip parts of it to loosen it up and make sure there's no rubbing or friction going on. So this is to protect the area and maybe take an area of non-uniformity and make it uniform. So if the ankle's a little too small, but you still want to use the high compression bandage, you could build up the ankle to make that circumference a little bit bigger. And you can make something that instead of going, kind of wavy, that it's going to be more of a straight, uniform shot. And that's going to help you make more uniform levels of compression to be more graduated. Okay, so that's the idea of one kind of under padding. And then you've got your different types of foam. So I put just a little piece of foam on your table, but basically there are different layers and types of foam. There's the thinner, a little bit lighter, there's a little bit thicker, and then there's the different densities. So this one is much more dense and thick. Why you would use any of these is variable. One is, if they have a lot of hitting edema, and they've got a significant amount of edema, and you're just kind of getting started, the problem is you could get huge dents. You could get dents that, instead of just being surface dents that are maybe a little itchy and uncomfortable, they are significant dents that turn into a tourniquet. Because when you wrap somebody and they've got this much pitting edema, you can get this focal area and the bandage just sinks in, and so it's not uniform. So you could use something like foam instead of, if the padding that's lighter isn't going to give you good enough protection, you could use a piece of foam, whether you wrap it around or maybe just from on the top of the foot, from the base of the toes, one long strip all along. That's going to prevent it from sinking in up here. You could have the same idea, maybe one here and one just up along the back of the calf, in order to give protection from it sinking in like that. If you wrap all the way around, the pros and the cons. The pros are you're not going to get those big dents. The cons are your circumference just got much bigger and they're hot, and you could have that added discomfort and decreased level of tension that you're going to get produced. So pros and cons to each one, but it can come in very handy to have. If you have a problematic spot, so maybe you don't need this all through it, you just have one spot, maybe right at the ankle. You could do either a cuff around the ankle, or you could just do a piece up and kind of framing it in order to prevent that from happening. Okay, so foam can be good. Another thing foam can be really good for is scar tissue heating. The amount of heat that you get is it's gonna retain some heat, and that can help if you have some fibrosis. So it might be certain areas, it might be a place where you want to promote a little bit more heat retention, and when they exercise, that little area of heat and constant movement and friction is going to help with soft tissue mobilization. So again, there's a lot of things that you can use it for creatively. There's another type. This is another type of under padding. It again is really like not woven, but it's different than that type of cast padding, and it can be a little bit thicker. There are a variety of products that you can purchase, or you can sort of, you know, be creative yourself that can create uneven areas. And so yesterday when we talked about lymphedema and we talked about the friction on the skin, a lot of times when you're wrapping for the purpose of lymphedema, you want to have something underneath there that when the person does their exercises, that it's promoting that very low pressure, but it's promoting that movement of the skin instead of the deep pressure. And so that little movement can be beneficial. So when you think about the different products that you put under there, that little bit of tackiness, the uneven layers, that combine with the movement to pull and push horizontally, not vertically. And so that can help add to the whole manual lymph drainage process. It can be carried on when the person exercises on their own. Does that make sense? Okay, so, all right, so we've talked about a lot about single layer and then the combination of layers. Then there's products that come as a layer. Like this is a Coban tube, so there's different products that have come in naturally layered. This particular product, there's a regular and then there's a light one. And so you have two layers. The first one is foam on one side that goes against the skin, and then it's backed by a Coban. So when you wrap it, you have to really wrap it exactly right. The problem with Coban, the pro and the con. The pro is when you wrap something, like this is a brand name, but there are self-adherent wraps that basically adhere to themselves. They're unforgiving, so you have to wrap well. So when you wrap, it's going to kind of stick to itself, and however you wrap it, it's going to stay that way. So the good thing is, if you did a good job and it fits them perfect, and it's still going to fit them perfect later, then it's going to be a nice custom wrap that's not going to slip or anything. The second layer is an additional self-adherent wrap, and it's going to stick to itself. So it's going to really prevent it from slipping and sliding. So it can be very helpful when you reach, in my mind, more of a steady state where you want to kind of stay. The problem, because there are pros and cons. So let's say you wrap somebody really well and it fits them perfect right now. And you tell them, I want you to exercise, I want you to move, because it's a non-elastic. The compression comes from exercise, work, high working pressure. So you tell them, I want you to walk, I want you to walk at least this much period of time for the amount of time your legs are down. If they do it, and there was a lot of edema, and they're successful, and the circumference gets lower, then it's not tight anymore. So the problem is if you have a product that fits them perfect, but it doesn't have any elasticity, and the compression works, and their limb gets smaller, all of a sudden it's loose. It may kind of collapse on itself because it's not tight enough anymore. So multi-layer bandages may not be the products you want to use right away. You want to maybe start out with something that will allow you to unwrap and rewrap fairly easily, and then once they reach a point where you're thinking, okay, I don't think we're going to have dramatic volume changes from one treatment to the next, I could wrap them with a multi-layer bandage and let them wear it for several days. But what I don't want to do is wrap them with something that requires quite a bit of work to put on, and then have them exercise, and now it's not tight anymore, it's really loose and it wants to fall off. And it was meant to stay on for several days, but it's no good now after a few hours. So that's the idea with multi-layer bandages. So those are 2-layer bandages. This particular one is a 3-layer bandage, so it comes with basically a padding layer. It comes with an elastic layer, and this elastic layer has its own type of guide. So it has a guide that's basically rectangles. It's meant to make it into squares. And then it's meant to show you where to overlap and how to overlap. So again, this is the elastic component, and then it has an inelastic component. So it's another self-adherent wrap that doesn't have the rebound. And so anytime you have the multi-layers, what's the pro? Well, the pro is sustained compression. It's likely going to provide more compression, and it's going to be more sustained. It's usually a mixture of elastic and inelastic, and therefore, even if there's a little bit of a volume change, that elastic component is going to sort of take that into account. But the non-elastic component is going to give their resistance to expansion so that the exercise gives a good return on investment when they walk It gives that resistance. And they're also, because of the non-adherent layer outside, it's going to help prevent slippage and make it a little more comfortable. So multi-layer bandages can be anywhere from 2, 3, 4. So a 4-layer bandage, some sort of padding layer, some sort of non-elastic layer. This one is a crepe layer. And then you've got your elastic layer, which is that 50% stretch and 50% overlap. And then you've got your self-adherent layer that's going to kind of hold it all in place. Okay, so pros and cons. More work, more bulky, more thick, but the pros, well, that was a con. But the pro is that it will be hopefully some sustained compression and last for multiple days to maintain that level in order to get some healing to occur and less volume. So typically bandages like that are being done when people have not just edema, but typically they've got maybe some open wounds and you've got an appropriate bandage, wound dressing on, and you're going to wrap and you're going to get that sustained compression to help not have to keep going in and doing it again, especially if they're outpatient or maybe in a home health situation. Okay, single layer bandages, the risk you have is, you definitely have the risk of slippage. So when you wrap somebody and they start moving and so forth, they can slip and slide, and the amount of compression that you started with may not be sustained over very much time. So that's, again, one of the cons of just a single layer. But depending on your setting, I mean, for example, if you're in an inpatient setting, maybe a skilled nursing facility, hospital, a rehab type facility where they're inpatient, you could wrap somebody, and if all situation is right, and they have good working kidneys and their heart is in good shape, and you could wrap them with the appropriate type of bandage, and the volume could really start decreasing, and you could go back multiple times and rewrap it again as it gets smaller and have pretty rapid resolution. That would be dependent on venous. Now, if it's lymphatic, we don't want to be using compression to get the liquid out, because do you remember what we talked about? So if you use compression, you're increasing hydrostatic forces and you're removing the liquid. The liquid is going into the venous end of the capillary and you're getting it out that way. But it's not going to take the trash with it. It's not going to take the recyclables with it. You need that light compression and the manual type techniques in order to get that out of there. That's why you would not use elastic. I mean, I don't like saying the word ever, but elastic bandages are not what you're going to be using in a lymphatic patient. It's only for more the venous return. You would use non-elastic bandaging for lymph patients because you don't want to collapse those peripheral lymphatics, and it's not hydrostatic forces that's getting that liquid out of there. It's the stimulation of the lymphangions. It's the stimulation and movement of the skin to allow entrance of those solutes into the peripheral lymphatics. Make sense? Okay. All right, so compression materials make a difference. Let's talk about garments a little bit. When you think about compression garments, there's all different kinds. This is, I believe the ones here in green are Juzo products, but I just got them off, the internet, off people's marketing websites. Are any of our patients ever going to look like that? I mean, these people don't have edema. They probably don't have they might have an underlying condition, but for the most part, when you're dealing with edema patients, they don't typically, the garments don't fit this perfect. And even someone who is not of size and who does not have edema, they take these pictures of them stationary, but if they move around, if they try to put a shoe on, or they move around and put a shirt on or something, you still end up with pooching around the edges of them. You end up with some discomfort. There's a lot of, there's a lot of things that can happen. And so compression garments, the big problems and the pros and cons, they're much easier to put on than a wrap. Wrapping takes skill, time, effort. You have to have physical mobility to be able to get to it, to wrap yourself, or the loved one has to be able to contribute and do it, or a caregiver. It does tend to require skill to get it on right and to monitor it. A garment, if it's properly fitted, The pros are it can be an easy way to maintain an appropriate level of compression, but the cons are they have to be able to get it on, and sometimes they're very difficult to get on. So donning and doffing is challenging. The higher the level of compression, the harder it is to put it on. I have a few different products over here. Let me just see what my next slide is. Yeah, so I have a few products here. Are you guys familiar with like 2B grip? Yeah, I mean, so I have a gauntlet. I have a couple of different products that you can try. So this is just, this particular brand is 2B grip, but there are a variety of companies that offer products like this. So they're tubular bandages. You can buy them in either individual strips or you can buy rolls of it. So these were on a roll and I just cut pieces off. So this kind of bandage can be utilized on the appropriate size limb, and they can be something that will work as well. But garments, again, are nice. They usually fit the shape of whatever limb. But the problems you have to measure them right and find the product that's going to work best for that person. Sometimes they're too long. I've had the situation where whatever we had in stock, if we put it on, it goes above the knee, or it goes all the way to the knee. And you don't want that. You want it to be to just below the knee, because when they move their leg, it's going to roll over and it's going to create a potential tourniquet. So sometimes I'll actually see the patients with it rolled over or folded over. They'll have it folded over. The problem there is you're increasing the compression exactly where you don't want it. You're getting it more at the proximal end. So the better situation would be to pull it down further and cut off the excess that you don't need. So remove at the toe area. But then sometimes you lose the location of the heel and it may not fit exactly perfect. So finding the product that's the right length, the right size, the right dimensions, even the fabric it's made from, sometimes they're more like nylon material and they don't have airflow, and so they can promote smelly, sweating, and so forth. Okay, so the different types of bandages. And then there's other products, like this one is called Edema Wear. And so when you look at, as it's stretched, it's got basically, I believe they describe this as cornrows, but basically it follows a little bit more that netting idea of giving you uneven pressure, and so when you're moving, it's helping to a little bit more mimic the philosophy of lymphedema, where it's not just compressed and pushing down, it's giving you some sort of a push and pull with low compression. So again, there's a variety of different products, and you can look at the different pros and cons of each. So donning and doffing, the amount of compression, uniformity, how uniform it is, comfort, you know, all of those things are going to come into play. Okay, and then there's compression alternatives. This particular one is a Circade. I have an example of one here. There's a number of different products that are alternatives, and what you do is, for this particular one, you can see it has sort of a key and a keyhole perspective. So if you laid somebody's leg on this and their foot is down here, and you wrapped these around, this end would go through here and they overlap. So it ends up looking like this. I don't know every brand out there. I know there's one called FerroWrap. There's a number of other products, but if you look up compression alternatives, you'll come up with a variety of different garments. So the pros and cons about this one, well, con-wise, it's more costly. So they are costly, but when I say that, I mean it's all relative. If they're going to comply and they're going to get good results, these are going to last for a long time, and then it's absolutely worth it. What can happen is when it's on, this particular product is not elastic. So it's basically your Velcro overlapping product. If they comply and they do their exercises, then what can happen is it can also all of a sudden get loose in places, and they can sit down and just tighten it. They can just tighten how overlapping it is in certain areas. If they end up in a period of time where they're a little bit bigger, maybe they were sitting up for a longer period of time that day, or something happened and they were expanded a little bit, because there are a number of people that you're going to encounter. The reality of getting a perfect steady state that they're going to be able to wear the same garments every day that slide on and have them fit perfectly may not be a reality. So you could have somebody that just fluctuates too much, whether it's because of noncompliance or because it's their pathology. That's that's going to have to be dealt with. And so sometimes this might be a good option because they can accommodate for those big fluctuations. These types of products, the more rigid they are, they might give more aggressive compression when they walk, but they also can have those rough edges. So the more tough they are and firm, the more, especially around the ankle and the knee, if they don't fit perfect and if they move, they can actually get some, rub themselves raw in certain places. Some of the softer fabrics may feel great right off the, right when you purchase it. You can get them custom measured for people, or you can get off the shelf ones. I had somebody not too long ago got, it's a newer version of this, and she's been doing quite well with it, but it had to be custom because her shape was unique and the off-the-shelf ones wouldn't fit. And so they were more costly, it took a little longer to get it. But the less firm the fabric is, the more comfortable and elastic it is, usually the less life you're going to get out of them. They usually wear out a little sooner. So again, pros and cons. It also doesn't always look like this. I mean, if you go to put it on somebody, you'll see the one I have over here. I was going to lay it out. It's literally, or put it away after my last course, it's just a gob of Velcro. It's just all, kind of like what we're about to do, get our Christmas lights out and try to untangle them from last year. But that's the idea, is they're not always as easy to put on as this looks. If you don't take it off carefully and store it the way you should, it ends up a big jumbled, they could be a big jumbled mess. But the instructions, if you follow the instructions, they can be easier. I also have another product. This was new to me, but it, again, is a little more similar to what a lot of companies are starting to go towards. This particular one is, it's called Extremities, but basically, these are your Velcro pieces. They overlap, so they're much easier to kind of pull, and it has a zipper. You put it on, you zip it up, and then you can tighten or loosen at certain areas. So I've got a couple of these that if you want to try them. And so these are based by Amerix Healthcare, and I have some handouts on that as well.
Comes in sizes.
Comes in different sizes, and I have 2 different sizes here. I have a couple of different sizes here, and there's an underpad sock that you put on. Okay. Speaking of underpadding, stockings, another thing, I think I put a piece of this on your table. This is just Tricofix, but you can get, a number of companies make tubular bandage, and basically these can be nice, just a little stockinette type of thing in order to put under any product that you put on to give just a little bit more comfort and just make it feel better. And it doesn't really necessarily take up for the wrinkles, maybe very small wrinkles, but it can add to the comfort level of it and can prevent some friction that you might get under some products. Okay, so a variety of different compression alternatives. They're more sort of adjustable garments that you can wear that can help with compression, especially when it's more not as predictable and not as well maintained. They don't have a good steady state, they fluctuate. Intermittent pneumatic compression. We haven't talked much about billing, but the sad case is when you have compression needs, a lot of products are only reimbursable during an acute phase and during maybe if you have an incision or a wound. It's something that is being looked at, and hopefully we're going to end up in a better situation. But staying up to date on what's reimbursable, what isn't, and how to get it reimbursed and things like that. Use your company. If you have companies that you deal with, a lot of people contract with a single company that has a line of products, or they can use whoever they want, and you then have to call somebody and talk to someone. But it's very helpful to refer to manufacturers because they're usually up on whatever the latest and newest thing is that's going on for reimbursement. Because I'll tell you, it's a challenge to stay up on all these things that constantly evolve. And it's not even that, but if this third-party payer might be different than that third-party payer, and it evolves. And from one setting to the next, it can be different as well. So even if it's, a certain third-party payer, it may pay differently when they're in a hospital than if they're in an outpatient center, if they're Part A, if they're Part B. There's those differences. So again, using those manufacturers. You can also look to the local coverage determinations. So depending on where you work and who you deal with, you're going to have a different list of local coverage determinations, which give you guidance on what is paid for and what isn't paid for. It's always good to read those documents simply, even if you're not going to memorize it, because they're really hard to keep up on. But look at the language they use. A lot of your manufacturers will provide this information for you to make sure that your documentation is supporting the need. It's not always that you're saying something different than you would have said to begin with. It's just using the terminology that they're looking for to explain why the need is there. So local coverage determinations are basically based on your intermediary, well, they're not intermediaries anymore, but your Medicare administrative contractor or whoever your insurance carrier is. And then there's national coverage determinations. There is a national coverage determination for intermittent pneumatic compression. These are just two pictures just for entertainment, but the idea of intermittent pneumatic compression, they can be designed based on the principles of lymphedema or designed based on hydrostatic forces. So I know when I was in school, we learned just hydrostatic forces. At the time, there weren't any based off the idea of lymphedema. And so it was basically like, it was from distal to proximal. And basically it would squeeze, if you had the devices with multiple chambers, it would be tighter at the foot, and then it would release, and then you'd have the ankle. Even those products, I would like to reverse it, where you would have it squeeze at the thigh, and then release, then squeeze at the knee, then release, then squeeze more at the foot, because that would better follow the principle of make room, and then bring it along the way. Make room first, clear proximal first. From a lymphedema perspective, those products are a little bit more in the line with something like this, where they provide the compression proximally first. They give you a little bit of a squeeze and a hug, and then they release, and then they do a squeeze and a hug more distally, and then they release. So they typically will follow those kinds of principles. The problem I have with any of these things is number 1, 2, and 3 is not a part of the process. Cardiovascular exercise, diaphragmatic breathing, trunk exercises, proximal to distal muscle contractions. I mean, none of those, which are such a key part of edema reduction, none of those are facilitated. One of my invention ideas would be to kind of have a verbal thing that's guiding you. Maybe this is adding to it, but it's also telling you, take a deep breath. Now do whatever. You could even record it yourself. There you go. Maybe I'll do that over Christmas break. Have a new invention. But the idea there is, I don't want to promote sedentary behavior. And if I could do it somehow else, I would much rather wrap the person and have them up, moving around, and promote mobility. But if they can't move, they won't move. It's not going to happen. This is someone who is currently immobilized. Maybe they are in a coma situation. They're intensive care. They're immobilized, and it's not realistic. Then I think it would be a nice added adjunct that could work. But again, it wouldn't be my first choice. Okay, I think that's good for that one. All right, so let's talk about contraindications and some complications that you might run into, some precautions, and some contraindications. So we talked a little bit about congestive heart failure yesterday. Heart failure, congestive heart failure, it's not a single standalone thing. It's usually something that has happened over a period of time. There could be acute congestive heart failure, which comes on suddenly and it can be resolved suddenly. It could be the examples we talked about yesterday in the lab where there is urinary retention or there's something but it's temporary and it can be resolved. That is a very different scenario than your chronic congestive heart failure. Chronic congestive heart failure, it didn't come on overnight. It's built up over time and it's been slowly, it's a persistent, lasting, slow to build up condition. It's generally a combination of maybe some kidney failure issues where they're not excreting perfectly well, high blood pressure, inactivity, sometimes there's obesity, there's diabetes, there's just a combination of things that results in this burden on the heart. And the burden on the heart is causing it not to be able to pump this liquid, so we talked about this as a closed loop with a motor. Well, the motor is just overwhelmed, so a lot of times the heart becomes enlarged, it's not capable of doing a really good pump, empty and fill. So it's too overwhelmed. There's no one level. So there's congestive heart failure that's, they're at high risk, but they're well controlled. They're being medicated and it's being managed, but they're, I joke around, it's not funny probably, but they're a potato chip away from landing themselves in the hospital on IVs again. So you have people that are just barely keeping that steady state, and any little meal or day of inactivity or a medication that they take over the counter that could cause a little bit of a blood pressure increase, all of a sudden they are not in control and they're in the hospital. So there are people that are well managed and people that are really difficult to manage. Those are all going to have to be taken into account by you when you evaluate a patient. Just to say someone has in their medical history, their prior medical history, congestive heart failure, to say that they're not a candidate for something is an overstatement. You have to look at whether it's a yield sign, proceed with caution, or whether it's a stop sign. And for me, the amount of edema they have, if the more edema, the slower you need to go to make sure that they're safely excreting that excess amount of liquid. You definitely can't go aggressive with anything. Exercise either. I mean, it's not just external compression, but any of these methods that we do, you could get too much liquid added into their venous system, and therefore they're overwhelmed. They're further overwhelmed, their blood pressure goes up. All of a sudden you go in to see them the next time and they say, I might be getting sick, I coughed all night. Red flags should go off in your head. They may not be getting sick. You may have caused some pulmonary edema. So again, think about those things, think about their vitals, think about their risk factors. So some signs of congestive heart failure are, when you think back to that little squeezy toy where they squeezed it and the eyeballs popped out. I mean, the idea is if you're trying to take edema from one place, usually from the periphery, and bringing it in and you are successful, the circumference of that area got smaller. There's less liquid there. Did they lose weight? That's a big question. If they didn't lose weight, well, where did that liquid go? It could be in their belly, that's ascites. It could be in their vascular system and their blood pressure went up and their heart is now not pumping in as well. It could be in their lungs. It could just be proximal. And now they've got this big shelf where their thigh is super swollen. But again, it's all a degree of where is the fluid going, where do you want it to go. That's where I always say, listen for the toilet flushing. Every time you think about edema, and you tell the patient, take a deep breath. Did you hear the toilet flush? Are you urinating? Did you lose weight? That's going to be a good way of just kind of checks and balances for safety. Okay, some other things to think about. Cancer. If somebody has active cancer and they're under the treatment of a physician, talk to their physician. Talk to them about what can you do, what do they not recommend. The philosophy is changing, but I can't guarantee exactly what the philosophy of that particular physician is going to be. So to protect yourself and protect your patient life is communicating with them. You could have, I wouldn't proceed with any kind of manual lymph drainage or compression products until speaking to their physician and finding out what their recommendations would be and be able to write that down. The thing about how cancer travels, it depends what kind of cancer it is, and I'm certainly no expert on it, but the reason they look at your lymph nodes is because it's a solid. It's the cells that are going from one place to another. So it's not going to go back into the bloodstream with compression because it's not going to pass that semi-permeable membrane of your capillary, but it's more going to go through the lymphatic system to be transmitted from one place to another. So the fear there is, if we promote lymph mobility from that site, could I be promoting the spread of the cancer? Well, the challenge I have is it's a little mind-boggling because the reality is if I haven't taken a deep breath, that's a part of my lymphedema treatment. You know what I mean? So what can't I do? And that's where a communication needs to take place, and the patient should be involved in that communication where you guys discuss pros and cons of all of these philosophies. And that's, again, where I can't say yes or no on every person, but I would say without guidance from their physician, their treating physician, I would not proceed without talking to them. Kidney failure. There could be early kidney failure There could be significant kidney failure, there's someone who's on dialysis, and everywhere in between. That's going to determine whether it's a proceed with caution or a stop sign. Don't proceed at all. This is not the priority. This person will become unstable if you start managing their edema. They're barely hanging in there as it is. So again, you've got to triage them and see what's the priority here. The amount of edema, so the volume of excess liquid combined with their level of of failure, of kidney failure, is going to be a determining factor. And you may talk to their physician. You may have to set priorities. Let's say both of their legs are edematous, and you've got a yield sign. You can proceed, but you have to proceed conservatively and with caution. So you may start with one limb. I'd probably pick the worst limb, and start conservatively, especially if they have a wound or they're at risk for infection on that one limb. Start with some conservative levels, some exercise, and keep weighing them. Use their weight as a measure of whether or not they're having successful excretion and losing the excess liquid, or if you're just relocating it somewhere else. Also, you're going to follow their vital signs and work with a physician on those lab markers as well as how they're doing. So you could end up with a really, really improved outcome, because once you get rid of some of this excess liquid, it might be that they haven't been moving and breathing and exercising. You get them breathing, and all of a sudden it could stimulate some increased excretion. So again, it's just proceed with caution and monitor closely. Pregnancy, I mentioned this yesterday. It's if you're pregnant and you have significant edema, proceed with caution, especially if they have underlying venous disease or lymphedema. So it's something to consider, and also speak with their physician and proceed with caution. Sudden changes, any sudden changes, the edema significantly increased, could they have a DVT? Could they have some sort of a blockage of their lymphatic vessels? So if there's a sudden change, you proceed with caution, call the physician. Blood pressure changes, they could go in the positive where they're getting better, but you don't want to see that blood pressure going up as a result of edema reduction. That doesn't add up. It doesn't make sense. Their heart rate, so just obviously monitor their vital signs, and then any report from them that says, I just don't feel right, or listen to what your patients say. Let your patient's body tell you a story as well, through their vital signs if they can't verbally communicate with you. But if they have just overall something that they feel is not right, step back, do your triage. Are they going to the bathroom? Are they urinating? Are they having any kind of fever? Are their vital signs in this normal range? That's where you step back and you just do basically a full assessment again. Now, infection or cellulitis. The big thing I like to talk about here is what type of infection they might have. There's a big difference between an external organism they are infected with. So they were in the hospital, they had some scrapes or open areas or open wounds, they developed an infection, they were exposed to an organism, and they have a foreign bacteria that they're exposed to, versus their normal flora. So that's a big difference. So you might have somebody who has, who has cellulitis. Well, was the cellulitis a slow onset to an area that has had chronic edema? That's different than cellulitis to an area where they got bit by a bug, they swelled up, they developed an infection fairly rapidly, or they had a cut or surgery or a scrape that they had a traumatic injury that became infected. That's different than the person who just had edema that was more chronic in nature, and then they developed an infection. So what's typically different about it is what organism it is. Your chronic cellulitis type of patient is usually their normal flora. So basically the problem is their immune function. And so the normal flora now has just started to not be, their normal immune function is so impaired that the typical flora has sort of taken over. In those cases, again, you've got to work with the medical team, work with the physician, But if you're dealing with somebody who has been taking antibiotics 3 times a year because they keep getting cellulitis and they've got this chronic edema, if we work as a team together and we can get the edema better controlled, they may not get cellulitis again. That is typically somebody who had pitting edema. Picture that interstitial fluid as just being stagnant and full of waste, and therefore managing their edema and getting a good overturn and having them then be fitted with a type of compression product combined with their level of ability physically to be able to maintain good superficial blood flow. And that way you might prevent that, because cellulitis occurs in the superficial compartment. And therefore keeping that pitting edema at bay and keeping that superficial circulation going can help prevent it from recurring again. So the question is, when you have somebody present to you where you want to do edema management, they have an infection, what's the pathogen? What's the source of the infection? Was it acute onset, suddenly after their injury, traumatic event, or was it a slow onset? Did the edema happen quickly and then they developed cellulitis? Or did it happen slowly and they've had this sort of chronically? Those are all going to affect how you treat the patient. And when it's more chronic, then managing the edema is usually a big part of the problem, and that's going to be a cornerstone of getting that to resolve. Now, cellulitis can also look like a DVT or dermatitis. So you want to do sort of a differential diagnosis there as well. So somebody presents with edematous, hot, red, maybe painful lower extremities from the knee down below the knee. So you have the symptoms that could be cellulitis, could be a DVT, it could be dermatitis, any of those things. So you want to think about which one it's likely to be. So probability scales are going to be helpful. If they just started a new product yesterday, we just put a new compression wrap on them and they're red everywhere that it touched them, or there was something new being used on them topically, and everywhere, then it's probably an allergic reaction to dermatitis. If, on the other hand, it's, it's been slow onset, they've been edematous, and it more fits the description of a cellulitis, that's the most probable thing. Is DVT next? We're going to talk about DVT separately here in a minute. When you think about infection, your skin is automatically contaminated, so everybody has pathogens on them. And most of us as healthcare providers, if we culture different places on your body and culture your nose, you're going to be harboring and a carrier of some organisms anyway. I mean, I think you've probably all read about MRSA and how they culture and find, so many of us have it in our nasal passages. The fact of the matter is, if you're healthy, you're living in harmony with them. The good and the bad are in balance with each other. And, all of us know the balancing act and the gut and how it's involved. There's all these things that we can read about, that if you aggressively treat an infection, you very often will end up with a different kind of infection, because you may wipe out one organism, but you also wipe out your healthy flora, and then therefore now the fungus overtakes you. So infection is not a simple thing to deal with. It's a complicated thing, and it's not black and white. It's sort of a gray area. And that's where when you go in and you look, you're thinking about, where's the source? What are the signs and symptoms you're looking for? I think I had the signs and symptoms here. So, the redness, red, erythematic, will be warm to the touch. Edema is exactly what we're talking about here, is the primary objective of this outcome is to reduce the edema. Pain, whether it's local or getting worse, if they have fever or elevated white blood cell count, that's cause for concern, because that's a sign that it's more of a systemic reaction, and therefore they're likely going to need an increased level of treatment, whether it's oral or IV antibiotics. But the reality is, if it's just a local reaction, and it's a small local reaction, it might be able to be treated locally. If it's more widespread, it's also not enough to just go in and look at it today. You can't show me a picture and say, is this infected? It's not likely to be helpful. I need to know, can I see yesterday's picture? And can you show me tomorrow's picture too? You know what I mean? So the idea is, are these things getting worse? Are they spreading, or are they getting better? Because if it's getting better, whatever you're doing, keep doing it. Because I think we all would agree that antibiotic use comes with a price. And if we can treat things without it safely and effectively, then we would want to do that, but it's not always possible. So we're challenged with working as a team to try to treat as aggressively and appropriately as possible without the side effects, if we can. So when you think about local, you're not going to wipe out your normal flora. That's not a realistic thing. You don't want that. So the local contamination, just looking at what organisms are present, is always going to be misleading because there's going to be foreign, or pathogens that could be potentially harmful if they are in high enough number. Now, if they have an infection, again, even just saying there's an infection is a difficult thing. There are various companies that have come up with, like the nerds and the stones, and the different algorithms that help you decide what to do. I know the CDC has various algorithms to help you determine what steps and measures should be taken. But again, there's a whole lot of thinking and hypothesizing that should be done. And as a team, you can be a big part of it. You can talk to physicians, you can talk to the patient, you can usually spend enough time with the patient, you have a little bit of a better picture of their compliance, their level of physical activity, what you think is going to be beneficial and what's not, because you see if they can move, will they move. So those are all going to be very helpful pieces of information. So if the infection seems to be localized and superficial, can it be treated locally? Do they really need anything systemic going on? If it's more deep, if it's getting worse, whatever measures you're doing, change it up. If it's spreading, then they might need, if it's an open wound, they may need a culture and an appropriate level antibiotic. If it's not open, they may need assessment by another medical personnel. So to be able to judge when to act is important, especially in a home health environment when you have to make that decision. If when in doubt, have them worked up. Call the physician, explain what you're seeing, do your triage, take your measurements. But I'd rather overreact than underreact if there's a chance of, and especially if you're not going to see them for a couple of days again. Let's talk about deep vein thrombosis. So DVTs, they are in the deep compartment, and this is where I see people having a false sense of security that if they put compression on, they're not going to get a DVT. And the reality is that doesn't necessarily move blood through the deep compartment, so that alone is not going to be, is not a standalone effective tool. So it's difficult to detect on physical exam. So having a limb that's red, hot, edematous, again, differential diagnosis between possible DVT versus dermatitis, some sort of, or cellulitis. There are also clinical prediction rules. Like this particular one, this is the Wells clinical prediction rule. There are things you can do to look at probability. And so it has you do a count. You do these questions whether it's present or not. And so looking at the signs and symptoms, acute cancer, they've been treated within the 6 months, or they're on palliative care. They have paralysis, paresis, or immobilization of the lower extremity. They've been bedridden for more than 3 days because of surgery, or surgery was within the last 4 weeks. Localized tenderness along the distribution of the deep veins, so palpating along that line of the deep veins for pain. The entire leg is swollen. Unilateral calf swelling of greater than 3 centimeters, unilateral pitting edema, collateral superficial veins. Alternative diagnosis is as likely or more likely than DVT, and that's your differential diagnosis. For example, they just started this new rat yesterday. It's more likely that it's dermatitis. Or they've had this for a period of time. It's superficial. It seems more probable that it's cellulitis. So that sort of clinical prediction rule and that debate, and then you document it. Looking at what their recent history has been, looking at the risk factors, communicating with the physician, coagulability, are they on medications for anticoagulants and so forth, the way the pain presents, where it presents, how the onset of the edema, and those are all going to help you make a more probable decision, and then you communicate with the physician. And I can't stress enough how much prevention is the key. Okay, so let's just go through a little bit of a summary. In their history, if you're looking at someone's history before you go see somebody and do their evaluation, reading their history, and they have the things you're going to see in their history if it's acute. Well, something happened. They had a recent injury, trauma, or surgery, so there should be some sort of an etiology to explain what the injury is. If you think it's venous, the things that you're going to typically see are current or history of DVTs. Those are in the deep veins. That's a sign that the venous return is not sufficient. It's impaired. Varicosities. Looking at their history, you may see that they've had DVTs in the past. They have, signs and symptoms of varicosities, and they've had them in the past. They're obese, and they've been chronically obese, especially multiple pregnancies, inactivity, smoking, having a history or current venous wounds, which are proximal to the ankle, distal to the knee. From a lymphedema standpoint, so primary lymphedema, we talked about yesterday, is not the most common. It's much, much more common to have secondary, but it's possible you'll encounter somebody who has a condition with a congenital disposition for lymphedema. They could have injured the lymphatics, which any number of things could injure your lymphatics. The most common is cancer treatment, lymph node removal, radiation, those things that are specifically the most common things in the United States that will cause, breast cancer specifically is the treatment for breast cancer is the leading cause of lymphedema, secondary lymphedema. But primary congenital, it's possible to happen, but you could also have somebody who has secondary injury to the lymphatics, whether it was a traumatic injury that damaged the venous system, but it also damaged the lymphatic system, could very well result in adhesions, so the scar tissue results in some blockages, or they may have actually lost some of those vessels. Surgery, trauma, having chronic edema, the veins and the lymph vessels are married. They basically are very related. It's hard to have an issue with one and have it not impact the other. So in somebody who has had venous disease, maybe they were obese, fairly inactive, and they have developed slowly over time damage to their venous system, and then they started that process of their legs swelled, they got better overnight, and and then it got worse. It's not uncommon for the chronic venous to become now mixed etiology and have more than one. So signs and symptoms of acute, the things that we've been talking about throughout yesterday and today, erythema, so redness, the heat, the vasodilation that's bringing in all that extra blood flow is a good thing, but it's going to cause edema, redness, warmth, increased pain, and decreased function. So the pain, again, due to the chemical mediators being present, which would respond better to manual lymph drainage, but also due to the edema, which you can try, if you reduce the edema, you'll pretty quickly decrease the pain and increase the function. So the venous system, lower leg edema, that improves with elevation. That's a really key thing, is that it improves overnight with elevation. Hemosiderin staining, the discoloration that you get that's not sudden onset. It's a chronic, slow to occur that has happened over a period of time. Weepy tissue, that's the sort of as it evolves, there's too much liquid in the venous system, so it leaks out of the interstitial fluid, causing this edema. And then if there's too much interstitial fluid, eventually it actually starts leaking out of your skin, and you get this weepy tissue that's sticky, tacky, can become almost crusty. Pain. Let's talk about pain for a minute. There's a variety of kinds of pain. If you have venous pain, it tends to be more painful. Well, if they have wounds, there's often pain when they change the wound dressings. But typically the pain is more with sedentary in a dependent position. So that's an indication of venous pain, but it should improve with elevation. If you have somebody whose pain is on elevation, that's more likely arterial. So looking at the pain patterns, if it hurts when they walk, So let's say you've done some short stretch bandaging and you're telling them, I want you to walk, and they're getting cramping sensations when they ambulate. Red flag should be going off in your head. Did you do a good arterial assessment to make sure they were safe? So that's something important, if you didn't already do it, to go back and do it. Open wounds, and where are the open wounds? So typically from a venous condition, they would be proximal to the ankle, distal to the knee in that gaiter area. Most commonly proximal to the medial malleolus. Pulses are usually palpable. They may be a little bit difficult to palpate because of the level of edema, but you should be able to palpate pulses. And over time, there could be tissue changes resulting in fibrosis, especially in that gaiter area. From a lymphedema standpoint, the key is that the edema does not improve with elevation. And that's a good indicator that these are not hydrostatic forces that are causing the problem. It's osmotic and oncotic forces. So it's more the makeup of the solutes that are in the interstitial fluid that's the problem, not so much the hydrostatic forces. Stemmer sign is that, a positive stemmer sign is that inability to pick the tissue on the top of the toe. Late signs is over time they can become fibrotic. Okay, so some treatment options for acute. What do you do for acute? Well, if it's uncomplicated, you do the same thing you do for yourself during an acute injury. You elevate, rest. So the RICE method, let's talk about this for a minute. RICE, rest, ice, compression, elevation. It depends. I mean, yes, certainly the day of the injury and when it is not safe to move, mobilize, and exercise. But generally, by the time we see somebody, especially in a setting that's more subacute, even though the problem might be fairly recent and we're still considering it a fairly acute problem, meaning it wasn't really a chronic problem. They had a car accident, they sprained their ankle, they broke their leg, broke their arm, something like that. At this point, the question is, do they really still want to rest? Do we still want them resting? And a lot of times I'm like, no, your resting period is over. At this point, we need to do judicious movement. And we want to guide them. What kind of judicious movement should we do that's going to get the best bang out of the buck? If they're really tired, they're in a lot of pain, this is going to help them move on past that period of time. We may need to re-educate them because they may have been told in the hospital, stay ahead of the pain. Don't wait till you're in a lot of pain. Take the pill before you reach that, that level of pain. At this point, we're going to completely have to undo all of that because that's not the philosophy you want to keep on. How are you ever going to know when you can wean off of it? So the level of injury, the person's probability of healing is all going to help you determine at what point can you start moving and mobilizing and decreasing pain, pain pills. Ice, that's another thing. Cold, early on, cold can be very helpful. It's helpful for pain management. It may prevent increasing edema from forming, but at some point, if they're using too much cold and they have superficial skin damage, you may be prolonging that because I don't necessarily want to have them, off and on throughout the whole day having a period of vasoconstriction going on. So at some point, you may want to wean off of the cold if you find that the superficial tissue is not healing properly. Manage the pain. I like the word manage because yes, pain medication may be appropriate and necessary still, but you want to be managing it in a way that you're starting to educate the person. One of my very, very common pain-related goals is that the patient will be able to list 3 things they can try prior to taking a pain pill to start helping them respect the idea that there are other things you can do. I may also have a goal that says patient will be educated and demonstrate 3, non-medication pain management techniques. So it could be for somebody long-term who has the high risk of becoming dependent and things like that. So it could be meditation, breathing, cardiovascular exercise, distraction. There's a lot of different things that people can do that will minimize their pain, and it's not medication related. Compression. If somebody has a normal venous return, normal lymphatic return, they still would benefit from compression because you're in a state of inflammation. So during that period of inflammation, sort of the gates are open, allowing emergency vascular flow into the area, but it's bringing excess liquid as well. So some compression combined with, appropriate elevation and exercise is going to give you a much faster and better outcome. So light compression, 10 to 15 millimeters of mercury, and appropriate levels of exercise. So this is where your expertise is going to come in handy, and that we want to market ourselves as how important it is to have skilled intervention. Now, if you have somebody with underlying complications, even more so needed, because if they have an acute on top of chronic injury, you're going to need to go the extra measures where they're not going to heal. An acute wound becomes a chronic wound. An acute injury becomes they don't reach the prior level of function because they don't heal quickly enough, well enough to resume their prior level. So if it's venous, what do? Well, the combination of elevation, compression, lifestyle changes like diet and weight loss, smoking, quit smoking, increased physical activity. So when we think about the method of treatment, we want to think about what does their day-to-day look like now, assuming this is chronic, that they have this chronic problem going on. What's something we can change about their day-to-day function and level of activity that's going to promote in more of a long-term change? And if we can identify one thing at a time and start building on it, then maybe we can get them to change their steady state. But the challenge is going to be compliant. If you throw too much at them too quickly, they may not. But a lot of them, they want to lose weight. Of course they want to lose weight. Don't we all? Doesn't everyone? And so a lot of times they wanted to lose weight. They want to be more physically active, but it's just hard. Maybe they're obese. They have this sort of habit. If you could sort of use weight loss as a bribe, because the good news is if their legs are swollen from venous problems and their heart works well and their kidneys work well, they're going to lose weight, and it's going to be impressive. So you can use that as the idea that, well, if you do these things, you will lose weight. So let's go ahead and start with a weight today, and then let's do some of our plan, our proximal to distal exercises, compression, elevation, all these things that are going to help them urinate out a great deal of that liquid. They lose some weight, and maybe all of a sudden they feel a little bit more optimistic and they will exercise more. So again, we can maybe maneuver this in a way that can make somebody more compliant because we educate them along the way. Okay, so what do you do for lymphedema? Well, complete decongestive therapy, so CDT, manual lymph drainage, that's sort of hands-on massage that goes along with it. But it starts with our basic principles, proximal to distal, diaphragmatic breathing, cardiovascular exercise, trunk exercises, absolute cornerstone to everything in order to get the exit going and make room for it to go, followed by the proximal to distal techniques in order to try to move it along through the lymphatic system. Compression bandaging. Compression bandaging is an adjunct. It's not the treatment method. It's going to add on to the prospect, and so you're going to use this as a piece of the puzzle, but it's to enforce that lymphatic massage, and it's to maintain the circumference decrease that you've achieved. It's not to push it out. So as long as we make sure we're not looking at it as pushing it out, versus from a venous perspective, to get it into the venous system, I don't like the terminology push, but essentially you're raising hydrostatic forces outside of the vessel to get it in. But if the vessel inside has lower pressure, it's going to move more easily. And to achieve that, it's the proximal to distal plan that's going to get you to have that lower capillary pressure. Exercise, remedial exercise, because in these cases with chronic patients, it's not that I want you to exercise once or twice a day throughout the week. I want you to exercise every hour, maybe every 20 minutes, depending on how bad their problem is and how conservative we need to move along. We might do something very light but more frequently. So the key is graded exercises that are going to be routinely done. Skincare. They're high risk of infection, so they want to meticulously care for their skin. Be cautious. Don't be going out and getting sunburned. Don't be, doing things in the yard that could cause you to get scraped up. You've got to be extra protected because those areas are at high risk. Self-management training, this is something lifelong, and therefore they need to learn how to manage it and respect that they have a problem. Even if they don't swell for months or years at a time, they still need to monitor themselves and follow those principles to keep it that way. And then appropriate compression garments. Nobody really wants to wear compression garments. I mean, they're typically not that comfortable and pretty, and I mean, there's a lot of companies now that make, you know, statement compression products that you might enjoy wearing, but for the most part, you know, finding what is going to work for them is different. Some people are going to need a wrap every day, or it's just not going to be controlled. Other people won't need to. Depends on the level of damage and their overall picture of how their lymphatic return is going to be. Let me just do a couple of examples. Where are we on time? We're doing good. So I want to do a couple of just examples here. So let's talk about some cases. You guys, if you have specifics that you want to talk about, but I've got a few here we can say. So let's say we have somebody who had a total knee replacement. They have, their edema's worse and their pain is worse since yesterday. So this person had total knee replacement, and you go in to see them and they say, my leg is more painful and more swollen than it was yesterday, and the leg is bright red and painful from the knee to the ankle. What are you thinking? Well, they just had a knee replacement. Is this just day 2? I mean, is that reasonable to expect? Did they not move all night and they didn't do what they were supposed to be doing? And therefore the most probable thing is they have typical post-surgical pain because they weren't compliant, and you need to educate them. Now, the other differential diagnosis would be, could it be, you know, the 3 things that it could be: dermatitis, DVT, or cellulitis, some sort of infection. Well, certainly, you do your differential diagnosis. Signs of infection. You know, looking at signs of infection, does the incision look swollen, infected? Is it more focal around that area of the surgery? Or is it down below and it's more just from the edema related? Did they just start putting some topical on or a stocking? Is it more probable that it's dermatitis? Or are they coagulation levels aren't in place and you need to do that probability test to see, is it likely that they got a DVT? So you would do your sort of differential diagnosis, and a lot of that has to do with where they were yesterday, how long after surgery are they, and all the factors that go into it. So you're going to do a differential diagnosis and try to figure it out. Now, if that person, instead of you going in, there's no redness, bright red, or painful below the knee, it still hurts at the knee, and they're definitely very edematous. What could you do? What would you do different than that? So there's no signs of infection or, you know, cellulitis or DVT. It's just you have a total knee replacement, they have edema and pain. What would you do? What kind of edema management would you utilize? Yeah, so this is more acute. So you think about these principles of judicious exercise, elevation, compression, maybe cold for the pain management, because perhaps if they don't take so much pain, you know, they may be not needing as much pain medication depending on where they are after the injury. But one of the things that, if you're seeing this kind of patient, you're going to do assessment, you're going to see if there is any kind of underlying chronic condition. So are we acute on chronic? Was this somebody that they didn't really exercise much, they didn't walk much, so they had some venous problems already? Their other leg actually was swelling some too because of their lifestyle. That might be somebody where we're going to have to work a little bit harder. Their chances of getting an infection is higher. Their chances of, you know, having cellulitis and having DVTs is greater because the condition of their venous system. So again, you're going to come about the treatment accordingly, and you may need to do high compression bandaging. You may need to be more aggressive with it. But regardless, if you use the principles of elevation and compression and have that edema resolved, the faster you resolve it, the less dependent they're going to be on those pain medications, which are counterproductive, and the less likely they're going to get an infection, and the quicker they're going to recover and resume physical activity. What about if somebody has hemiplegia? So let's say they have hemiplegia, they've had a stroke, and they've got a very swollen upper extremity that's flaccid. What could you do there? Well, I mean, some of the things that we would typically do with exercise, you can't so much do, but you could do compression, you could do elevation, you know, so the elevation component would be there. And so if they have, you know, my question there would be, where are they in the prospect of their stroke? You know, have they just had it? Are you rehabbing them? In that case, you could add electrical stimulations. The combination of electrical stimulation with elevation and compression would be better than just compression and elevation. So adding that motor activity, and it might help with recovery. But in these cases, positioning, protection, wearing compression is going to be important, and follow those principles. The other question I'm going to have for you is, do your whole evaluation. Are they swollen everywhere or just that arm? Are they doing the proximal to distal? One thing you can do is just having the arm elevated and compressed. If you combine it with good diaphragmatic breath, exercise what you can, work what works, so they can do some exercise to get the cardiovascular system going. That's going to have residual improvement. Maybe not as much as if they could exercise, but you know, it's going to help. So you still want to follow the overall principles of the first 3 steps, which is breathe, you know, do a breath, make sure they're urinating, always look at those things, but diaphragmatic breathing, proximal to distal exercises, those are all going to be super important, along with the cardiovascular exercise. So if they aren't flaccid, but they're weak, what would you think? Well, I mean, you're going to add exercises from proximal to distal. The challenge there is going to be, when we talk about compression, I want the compression to be appropriate, but I don't want the compression to limit their ability to move. So let's say that the person is just getting to where they're maybe 2 minus out of 5. They're able to kind of move that arm a little bit against gravity, but it's still pretty weak, and the edema is inhibiting it as well. So I want to get the edema out of there. So I would use the amount of compression that's still going to allow them to do that same strength movement. If the compression exceeds it, makes it harder to move, it's counterproductive. So think about that, the combination of things. Okay, but still follow the same basic principles of proximal to distal. Always those first 3 steps: breathe, cardiovascular, trunk, proximal to distal. Am I repetitive enough? The challenge there is that's just going to be a habit. Okay, so now somebody has both legs are edematous. One side is worse than the other. It's better in the morning and worse at night. So you have somebody who has edema that improves with elevation. So what's the underlying?
Venous.
Venous. So you're going to look for other symptoms. So the elevation improvement is your key indicator, but you're looking for hemosiderin staining. You know, you're looking for maybe a history of DVTs or sedentary behavior, or obesity, all those kinds of things. So what's going to be your treatment there? I mean, here we're looking at all these things. A combination of, you know, changing their lifestyle. How long has this been? How old are they? What's their physical functioning? It's going to be a combination of the basic principles of proximal to distal exercise combined with those first 3 things, the cardiovascular, diaphragmatic breathing. How are you going to choose compression? Do you think you want to do compression? Probably. I mean, if they have edema and it's venous and they have pitting, that's going to help with what? Superficial edema. So you're going to want to combine it with the deep management. So the exercise and elevation, that's going to move it through the deep compartment. But yes, I would want to use external compression. So how do you choose what kind? Thinking about choosing, there's a couple questions you need to think about. The biggest one, mobility. Exactly. My number 1 question is, can they walk and will they walk? If they can walk and they will walk, do you want elastic or non-elastic?
Non-elastic.
Non-elastic, exactly. So you're going to capitalize on their ability to ambulate, their ability to move, and you're going to use non-elastic. It's going to be more comfortable, and it's going to give you a better pump, a better distance between resting pressure and working pressure. You know, it's going to give you a good pump. And you're also going to capitalize on anything else. It might be that when you ask them, what do you want to achieve in therapy? What are your goals in life? What are your goals with your health? if they say, I want to lose weight, weigh them. Weigh them before you even start. And that way, if they lose 3 to 5 pounds in the between your first episode of care and your second episode of care, right away you say, there you go. See, if you stick with it, and then the load, maybe their excitement and their compliance becomes better, and then you also can have, the smaller the circumference becomes, the more effective your compression is going to be, because the smaller the diameter, the tighter the tension is going to allow. Okay, so if they can't walk, they maybe are they're old, they have other comorbidities that are preventing them from being able to walk, what could you do then?
Compression, but with elastic.
Yes, so you're going to have to use some sort of elasticity, which right away I'm not happy about that. That's unfortunate, because there's more risk with compression that is elastic. There's more risk of discomfort. If it's someone where you're going to have to put it on and leave, are they going to be capable of safety monitoring if it gets too tight, or they have an adverse reaction and they get a bit of a tourniquet effect? Are they going to be able to remove it and do what they need to do to keep themselves safe? So that's going to be your safety assessment to determine, can I even do it? Prior to putting any compression on them, what does your safety assessment consist of? What's a safety assessment before you do compression?
I would check for arterial flow.
Okay, is there adequate arterial blood flow?
Right.
Check pulses, palpate pulses, get an ankle brachial index, maybe even send them out, especially if they have a combination of factors, and maybe they're diabetic as well. You're going to have to get that safety evaluation first. So whether you can do that easily bedside, but you're also going to look for signs of arterial disease, such as hair presence on the toes, top of the foot and leg. If it's an absence of hair, that's a sign that it could be arterial. Capillary refill, pain with elevation, intermittent claudication, all of those same things that we've been talking about that are going to be your good underlying safety precautions. Okay, so if I'm going to do compression, if I start out with elastic, and maybe once this person starts to have less edema and you're maybe rehabbing them some, all of a sudden now they can walk, and they're walking a little bit more. You could maybe switch them to a non-elastic bandage, and then ultimately before their discharge, you want to get them in some sort of garment that's going to be more long-term, because the reality is if you have venous disease, it's just not going to just go away. So you want to find out whether it's compression garment that they have to don and doff, whether it's an alternative product. You're going to find something that's likely going to work for them. It may not be the absolute perfect thing that you want them to have, because you want them to comply. So sometimes what I want them to do isn't always what they're going to do. How about, so we have a skilled nursing facility patient who fell. So the person had a fall, and they have edema in their right ankle, and they're complaining of their legs at night, and their lower extremities are hairless. So this is someone with an acute injury with complications. So what are you thinking? Well, it sounds like arterial, agreed? Yeah. So they have symptoms of arterial circulation problems. So do you think their ankle injury is going to heal well? Well, it might heal. It depends how severe the arterial compromise is, but that's definitely a complication. And the edema is not going to help either. So you now have poor arterial flow in, not bringing all these good things, and then you've got this edema that's congesting the area even further. So this combination may make the person not as likely to heal. And the reality is someone who's already impaired, because they're in a skilled nursing facility, we're going to assume there's probably some functional impairment going on. The more time set in a sedentary position is going to make them even more impaired. So if they haven't already seen somebody for a medical workup, I would want that. So if there's anything that can be done from a vascular perspective to increase the blood flow, I want that to entertain that option. But do you think they're going to be, the odds are that elevation may be difficult for them because it hurts when they elevate. So what other things could you do? Well, I definitely would incorporate the breathing and the proximal to distal exercise and utilize anything they can possibly do to try to improve the blood flow. because active exercise will improve arterial blood flow if you do it right. And so I'm going to do, we're going to do a medical workup. We're going to see is there anything that could be changing about them to help improve arterial flow in. And then we're also going to work on graded exercises and positioning. If somebody is elevated and they start to feel a little bit crampy, and then you have them do ankle pumps, do a deep breath, a little bit of cardiovascular exercise, and that improves the feeling, then that's going to be ideal versus just putting it back down again. So anything you can do actively, especially from a cardiovascular, breathing, proximal to distal exercise, that's going to be a benefit, and you're going to really want to grade it so that they can do a lot of them throughout the day, rather than a lot at one time, because that's going to hurt when they try to do that. Okay, so somebody has persistent upper extremity edema. They had edema that started after they got a mosquito bite, and you find out they had breast cancer, and they were treated for it 5 years ago. What do you think? I mean, this might be somebody that if this is all you've had is this course, I mean, the reality is they have lymphedema, and they may not have had swelling for 5 years, but now all of a sudden they encounter an inflammatory response, and they may have been slowly getting worse over time, but they didn't identify it. So it's possible that there was sort of this buildup of protein in the interstitial fluid, but it wasn't that much that caused the arm to blow up. But now the sudden inflammation, it blew up, and it's going to be less likely to resolve and resolve quickly. And their chances of getting infection and any kind of cellulitis type of thing is pretty high, given the history. So, something like that, to me, depending what setting you're seeing them in, if that's the primary problem, I mean, they didn't fall and break their arm. They don't need necessarily, what they need is manual lymph drainage, they need lymphatic treatment. If this is all you've had and it's not your primary area of treatment and you can refer them, that's what I would recommend, that you refer them. But otherwise, because those that tuned in yesterday and that we talked about it, you definitely can work what works. You can follow the plan, and you can do the proximal to distal using avenues that already work. But that means not going into the area of edema. It means going up to it and then backing off. But ideally, I want you to refer. And then we can talk further during the lab about this one, about some possible ideas of things that could be done conservatively if you have to treat them for a period of time until you get them to another referral. Just a couple more examples just to kind of round things out. We're still doing okay on time. So let's say you have somebody who has bilateral edema. It used to get better with elevation, but now it's not getting better with elevation. So basically they had brown discoloration, they were sedentary and obese lifestyle. The edema now is not improving with elevation. What does that make you think? I mean, to me, this is a typical mixed etiology that you're going to probably encounter if you work in geriatrics. It's actually a pretty common situation where, they have this lifestyle that led them to venous problems. And the venous problems, maybe they were predisposed anyway because of varicosities and so forth, but that cumulative damage over time initially represented as more of a venous problem, and now it's become also a lymphatic problem. So what would you do in the case here? What would you do maybe different than if it was straight up venous? What's the difference between those two? Well, I mean, for me, it's the condition of the interstitial fluid. It's the fact that they have edema. Would the circumference get smaller if you did compression? Sure it would, but it would condense down the waist. Agreed? It wouldn't necessarily get the waste out of there. So my question to you is, do an assessment of the patient. The absolute for sure thing that you want to do is promote the whole program from proximal to distal. So that's always going to be a good thing. Yes, breathe and cardiovascular exercise and proximal to distal exercise is going to be a benefit. The question there is, what do you do from the level of compression? What do you do locally at the distal site? So my question is, have they had cellulitis? Is this something that they tell you they've had bouts of cellulitis? How does the skin look? Does it look like, they don't have active cellulitis now, but boy, if we don't do something, they're going to get it again? Do they have some fibrosis forming? Where are we in that area? That's going to help me determine how much manual techniques do I need to do at the site. Because the reality is, if I just want to get out liquid and I want to get it out through the venous system, I can do that whole program and I can compress and I can get that liquid out of there quickly because I'm going to put it right on the highway and get it out of their body. If they don't, if the skin doesn't look very good, we're getting fibrosis, they've got weepy tissue, in that case, the likelihood that they would get infection and so forth, that's going to cause me to want to do manual lymph drainage. So in that case, I'm going to do everything proximal to distal, but I'm going to end with a local manual technique. And I'm going to teach that patient how to do it if they can. If I do decide to do compression, what kind of compression am I going to use? Non-elastic. So I'm going to use non-elastic bandaging that's going to have low resting pressure. That way, the chances, if they do an ankle pump with the non-elastic bandage, and that bandage is being kind of, just sort of oscillated across their skin, that still fits the definition of what you would want to do to fill local peripheral lymphatics, because that's not pressing down with hydrostatic force, it's doing this medial, lateral, proximal, distal friction type movement. So that's going to be more compatible with it. And so I would start with non-elastic bandaging no matter whether they are ambulatory or not, and I'm going to promote exercises, remedial exercises, in order to promote that filling. Now, as soon as you can get that quality of tissue better, because you might be surprised how quickly, if you have a compliant patient who has, the ability to do some exercise, they may respond very well, and all of a sudden they're compliant, and they, because this is typical. They want to please you, they want to do well, and a lot of times this sedentary person all of a sudden is doing quite well, but we want to make sure we maintain that, and we have some sort of long-term thing, because the chronic patients may get better pretty significantly while you're treating them, but then if they go back to their old habits, they're just going to end up back where they were again. So, now if you have the same kind of condition, you're always going to do a safety check. So let's say they have sensory impairment. What would you do then? What would you do different? Well, depending on my setting, I probably wouldn't do compression, at least not high compression, that's for sure. I absolutely would not be doing elastic bandages on somebody who has sensory impairment. So if they have a mixed etiology that incorporates venous and lymphatic and diabetes with neuropathic changes, again, this person just went up on the list of people who will likely need an amputation someday. I mean, having those comorbidities all together is a high-risk population, because the very thing you can do to help the edema that's easy for them to do, which is putting compression on, is now contraindicated. So, and many times these folks, if they are diabetic, they probably have some arterial compromise as well. So you going in and looking at the complicating factors and all of the comorbidities together is going to help you determine what's the safest way that we're going to go. And, no matter what their back, complicating problems are, they most likely are going to be able to benefit from at least the first three things. The breathing, cardiovascular exercise. So that's your cornerstone that you're always going to work on. Elevation is typically going to be appropriate. And it's the question of what type of manual techniques are you going to have to do. Certainly putting compression on and getting it right into the capillary, the venous capillary, is much easier than having to do the manual technique. But the manual technique is worth the extra effort if the interstitial fluid is full of waste and you need to get it out of it. Does that all make sense? Feel like a good little overview? Okay, so well, we're still done early. So that's the end of part 2. Does anybody have any questions? I only have one from home. Okay, any of you guys have questions? No? Okay, going once, going twice. Thank you everyone at home. If you have additional questions that come in, go ahead and instant message or email, and I'll return your, I'll answer it that way. Okay, thanks for tuning in.